Hello, my name is Alan Utter. I'm at Arkansas State University, and I would like to welcome you to the 2020 Create at State Student Research Symposium. Over the 3-day period, 145 student research presentations will be delivered by a total of 165 of our students and 53 of our faculty mentors. At Arkansas State University, we feel that it's important not only that students understand the knowledge that's shared with them in the classroom from textbooks, but we also want our students to understand how new knowledge is discovered, how discoveries are made, how do you extend the body of knowledge in a given discipline. And you do this through the research and creative endeavors process. This process is typically referred to as a high impact practice, and we, or myself and we, the faculty, are big proponents of high impact practices here at Arkansas State University. Essentially, a high impact practice is when our faculty are working with students on an initiative outside of the classroom. And student research is a great example of that. Other examples include internships, practicums, study abroad, international study abroad, working with a nonprofit community partner, high impact practice, and again, student research, a big part of that. What are some of the other benefits of engaging in research from a student standpoint? Well, one, graduate schools are certainly looking for this type of experience, especially with undergraduates. They want to see that undergraduate students have the basic understanding of how research is conducted and how we implement and support research from a student standpoint. So again, increasing your opportunities for securing admission into graduate school. Employers are looking for this type of experience. Employers want to see that students understand how to ask a question, a good question, how to attempt to gather information to answer that question. How do they go about interpreting the information that they've collected from a statistical standpoint? How do they, again, interpret and analyze that information? And then finally, how do they disseminate that? Those are the steps involved in knowledge creation, that industry that employers are looking for in students. Finally, students also have an opportunity to ask questions that maybe nobody else has yet to ask. And this is another advantage of engaging in student research as an undergraduate or a graduate student. And then finally, I think one of the best advantages or the biggest advantages of engaging in student research is that it's fun. Students get to work alongside of our faculty members in a lab, in a studio, in a field setting, maybe on a stage, but students are actually rolling up their sleeves and working hand in hand, side by side of our faculty, and hopefully generating new knowledge and making discoveries. These are the hallmarks of the benefits of engaging in student research. I hope that you will enjoy the presentations that will be delivered over this 3-day period. I want to take just one moment and thank personally all 53 of our faculty mentors that have mentored these students in the research process, especially during these very challenging times as we're dealing with a pandemic. And finally, I want to just take a moment. I want to wish every student that will be presenting their research over the next few days the very best in your presentations, the best of luck. And I hope that all of you enjoy the meeting. Thank you.
Hello, I am Susan Hanrahan, Dean of the College of Nursing and Health Professions. I am very excited that our college has put forward over 75 poster and oral presentations for this year's Create at State. I know we usually have well over 100, but I'm pleased that our students and their mentors have agreed to participate in this actually very unique and exciting virtual forum. In our college, I think you'll see an eclectic array of research, which can involve either highly specialized equipment, survey research, or other methods of research. Most of the research that you'll see listed actually has direct application, so that's the cool thing about it. We can do quality assurance projects, we can do quality improvement projects, and all of these things, actually we can use federal guidelines or national guidelines and do comparative analysis to things that are going on in the clinics so that we can see what may actually impact clinical practice. Patient access, patient outcomes, quality of care, etc. So it really is a win-win for everybody involved when we do these applied research scenarios. Some of our graduates won't finish their research until the spring or actually this summer, and I wish that they could participate because it would even demonstrate more diversity within the college. But this year I want to thank all of our students who took the challenge to go virtual and their mentors, and so we do still have a quality showing of our research talent in the college, and I'm very proud of all of our students and our faculty who are participating in this unique forum. So, from the College of Nursing and Health Professions, everybody enjoy.
Hello, everyone from Arkansas State University, the College of Nursing and Health Professions. I am family nurse practitioner student Ashley Early. Today, I'm going to talk with you about an examination of statin therapy prescription rates among diabetic patients between the age of 40 and 75 with known existing cardiovascular risk. I'm going to be giving a brief overview of the introduction and purpose, objectives, methods, population, findings, discussion and action plan, acknowledgments, and references of the research that I have been able to participate in while attending Arkansas State University. It is estimated that there are more than 200 million people worldwide diagnosed with diabetes. Atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality for individuals with diabetes and results in an estimated $37.3 billion in cardiovascular-related spending each year. The purpose of this study is to compare the rate of diabetics prescribed statin therapy at a rural Arkansas clinic to the national average of approximately 32%. Diabetes affects the microvascular and macrovascular structures of the body. Patients diagnosed with diabetes can be up to 4 times more likely to develop CVD or stroke. It is for this reason that the American Diabetic Association, in conjunction with the American College of Cardiology and the American Heart Association, have recommended clinical guidelines to treat these patients appropriately. The results will help providers at the rural clinic gain insight into their performance as it compares to the national average. The rural clinic will then have a baseline performance level to use for future quality improvement goals. This study was conducted at a rural clinic in Arkansas, and a retrospective chart review was conducted of 50 charts using the clinic's EMR. IRB approval was obtained through ASU, and a data collection tool along with simple mathematical calculations were utilized to determine the percentage of patients receiving statin therapy. Inclusion criteria for this study included both male and female patients between the ages of 40 and 75 years of age with a diagnosis of diabetes using the ICD-10 code E11.9. The findings of this study found that the rate of treatment of statin therapy among the qualifying diabetic patients at the rural Arkansas clinic was 86%. In comparison, the national rate of statin prescription to qualifying diabetics was approximately 32%. The 86% rate of statin prescription to qualifying diabetics at this rural Arkansas clinic was significantly better. Hyperlipidemia is a disorder that affects more than 71 million people in America. These patients are at an increased risk for heart disease, which is the leading cause of death in the United States. This is a diagnosis that can be managed in the primary care setting, and diabetics are 2 to 4 times more likely to die from heart disease. This is why the recommendations put forth by the American Diabetic Association, the American College of Cardiology, and the American Heart Association should be considered. It is evident in the research that the initiation of statin therapy to those at risk for the development of CVD can regress hyperlipidemia and help to prevent a life-threatening cardiovascular event. The study of coronary atheroma by intravascular ultrasound, effect of rovastatin versus atorvastatin, or SATURN, was explicitly designed to look at patients with existing atherosclerosis. Aggressive LDL cholesterol lowering with high-intensity statin therapy can regress coronary atheroma and reduce the incidence of cardiovascular events in patients with established CAD. Primary care providers should consider the recommendations regarding statin therapy and consider prescribing to the appropriate patients to help prevent major cardiovascular events. I would like to thank Arkansas State University's Dr. Chris Jordan and Dr. Mark Foster from the College of Nursing and Health Professions for mentoring me and guiding me through this research project. I am so grateful and thankful for the time that both of you have spent with me. Thank you to Create at State for letting us present our projects in this format this year. And thank you to Arkansas State University for always supporting us throughout our education. And a big congratulations and best wishes to the graduating class of 2020.
Hi, my name is Megan Eder. I'm a second-year student in the Masters of Athletic Training program. My project is the effect of 2 5-week vision training sessions with baseball players. My faculty mentor is Scott Bruce, and my co-authors are Carlita Moore and Robert Bradley. This study examined the effect of 2 5-week vision training sessions on collegiate baseball players. A study from the University of Cincinnati showed that extra vision training could improve batting averages in baseball players. It has been reported that almost 80% of information processed by athletes during activity is visual, and with baseball specifically, that batters have about 0.7 seconds to decide whether to swing at a pitch or not. This combination of visual and motor processing is referred to as visual motor reaction time, or VMRT. VMRT has many aspects, including saccades, which is the rapid movements the eyes make when fixating on an object, peripheral vision, hand-eye coordination, and dual task processing. By training all these aspects, the athlete's VMRT should improve. The reflection edge is a new light board technology that can be used to train VMRT. Along with training reaction time, the reflection edge can also be used to assess accuracy and precision, which can tend to be very important aspects of a good at-bat in baseball. Previous studies have shown that training on a light board can have moderate to strong reliability when it comes to improving reaction time, although only one study has examined training VMRT in collegiate baseball players. The original purpose of this study was to examine the effects of vision training on the batting and fielding averages of baseball players, but due to the coronavirus pandemic, the purpose was modified to examine the effect of training VMRT on the reflection edge in collegiate baseball players. "22 intercollegiate baseball players were originally included in this study. 3 players voluntarily chose to leave the team, so a total of 19 players were included in the final analysis. The players attended 2 training sessions a week for 5 weeks in the fall and another 5 weeks prior to the start of the season. On the first day of training, the players were baseline tested using Big G, where the players were instructed to touch illuminated targets as quickly as possible, Go No Go, where the players were instructed to ignore red targets and touch green targets, and right and left execution or rail, where the players were instructed to hit yellow targets with their left hand and purple targets with the right hand. These 3 tests were repeated on the last day of training to get post-training numbers. Throughout the 5-week sessions, the players were given a number of tasks to complete on the reflection edge. The tasks got increasingly more difficult as the players improved. Paired t-tests were used to examine the differences between pre- and post-testing. Comparisons were made from pre-test fall to post-test fall, pre-test spring to post-test spring, and pre-test fall to post-test spring. We chose to use these comparisons for the final results analysis instead of batting averages because the season was cut short after only 16 games, with the players seeing less than 100 at-bats. Several parameters showed positive changes but were not statistically significant. There were also several parameters that were statistically significant. Of a total of 30 parameters, 8 were statistically significant, with accuracy and precision being the most consistently improved. Accuracy improved on an average of negative 3.77 millimeters, and precision improved on average of negative 3.53 millimeters. On the reflection edge, accuracy is how close to the center of the target box one touches, causing the lighted box to turn off, and precision is how consistently close each of the touches were to the center of the target boxes. This table shows the 8 parameters that were shown to be statistically significant in this study. Although the coronavirus pandemic caused for the cancellation of the 2020 baseball season, we believe there is still usable data in this study. Accuracy and precision are important factors in baseball when it comes to pitching, hitting, and fielding. The improvements in accuracy and precision from training on the reflection edge may be beneficial to on-field performance in the sport of baseball. I would like to end by thanking all the baseball players for participating in this study.
Hi, my name is Bridget Fender. I'm a family nurse practitioner student with ASU. My faculty mentor is Dr. Chris Jordan. My project is a local family practice clinic's colorectal cancer screening rates versus the national average of 67.3%. Colorectal cancer affects both men and women. It is the second leading cause of cancer-related deaths in the United States and is the third most common cancer in men and women. The lifetime risk of developing colorectal cancer is 1 in 22 for men and 1 in 24 for women. It is recommended by the U.S. Preventative Services Task Force that screening for colorectal cancer should begin at age 50 years and continue until the age of 75. Colorectal cancer screenings are a very easy way to detect colorectal cancer in the early stages and lessens the statistics of new cases and helps prevent death. The purpose of this study is to compare the colorectal screening rates of patients aged 50 to 75 in a local clinic in Paragould, Arkansas to the national average of 67.3%. IRB approval was granted through Arkansas State University. The study was performed using a randomized retrospective chart review. 50 charts were obtained from patients seen between January 1st, 2019 through November 18th, 2019. A data collection tool was utilized to include age, race, gender, and the ICD-10 code Z12.11. Inclusion criteria included patients greater than or equal to 50 years of age and less than or equal to 75 years of age. Exclusion criteria included patients less than 50 years of age and greater than 75 years of age. Data analysis of 50 patient charts reviewed resulted in 31 patients were screened for colorectal cancer, which equates to 62%. This is below the national average of 67.3%. This study reveals that a local family practice clinic falls just below the national average of 67.3% for colorectal cancer screenings. Every patient at every visit should be evaluated for need of screening. Recommendations from primary care providers play an instrumental role in patients' decisions to be screened for colorectal cancer. This concludes my presentation of my project, A Local Family Practice Clinic's Colorectal Cancer Screening Rates versus the National Average of 67.3%. Thank you for viewing my project, and y'all have a blessed day.
My name is Mary Hannah Pierce, and I'm a family nurse practitioner student here at Arkansas State University. And this is my poster presentation on the adherence to obesity screening within primary care in accordance to the United States Task Force guidelines. I would like to thank my faculty mentors, Dr. Mark Foster, my advisor, and Dr. Tammy Hawkins, my clinical instructor. My research was based off the United States Task Force guidelines for obesity screening. The U.S. Task Force recommends screening all adults for obesity. Clinicians should offer or refer patients with a BMI of 30 or higher to intensive multi-component behavioral interventions. I chose obesity because obesity has a great effect on morbidity and mortality because it puts people at risk for heart disease, diabetes, stroke, and certain types of cancer. It has increased significantly over the years and is the cause of many health complications. In the United States, obesity affects 38% of the general population. In the state of Missouri, where my research was conducted, obesity affects greater than 35% of people. Many physicians are failing to document obesity as a diagnosis on a patient's chart, and therefore not educating patients on their need for weight management. In a study produced by Fink, the results display that 65% of patients with a BMI of 30 or greater were not accompanied with a diagnosis of obesity in the problem list. And with obesity rates rising, healthcare providers need to be educating patients on obesity and making the proper referrals if needed to get these patients help. In recent research, only about 18% of obese patients receive counseling for weight reduction. According to LeBlanc, surveys have indicated that only 38 to 66% of overweight or obese patients have received a diagnosis of overweight or obesity, and less than half of obese patients report that their physician has advised them to lose weight or provided specific information about how to lose the weight. The purpose of my study is to determine the average utilization rate of the U.S. Preventative Service Task Force recommendation on screening obesity patients compared to the national average of 18%. This pie chart represents the national average. 18% represents the patients that are being educated or referred, and the larger section of 82% represents those patients who are not being educated or referred, 18%. The primary objective of the study is to compare the utilization rate of the U.S. Preventive Service Task Force guidelines in the rural clinic with the rate of use among practitioners across the nation. By determining whether the use of this guideline for obesity in a rural clinic is better or worse than the national average, providers at this clinic will gain insight into their performance and have a baseline performance level to use in order to set goals for future improvement. This descriptive study was conducted at a rural Missouri clinic through a retrospective chart review of 50 electronic medical records. Simple mathematical calculations were utilized to determine the percentage of patients who were educated in accordance to the U.S. Task Force guidelines on obesity. My inclusion criteria included male and female patients ages 18 to 65 with the diagnosis of obesity, and my exclusion criteria were age less than 18 or older than 65 and no diagnosis of obesity. The results of my study revealed that 100% of patients aged 18 to 65 are being screened for obesity, but only 32% were provided education or referred for weight management. The pie chart represents this clinic's adherence to the task force guidelines for obesity, where 32% are being educated or referred, and the 68% are not being educated or referred. In comparison to the national average at 18% of adherence to the United States Task Force guidelines for obesity, this rural clinic's rate is higher at 32%. And the graph represents that the rural clinic's adherence rate is 32%, which is much higher than the national average at 18%. When considering the guidelines for obesity screening and management set in place by the task force, practitioners at the clinic involved in the study were found to be better than the national average of 18%. Based on the evidence of available research, providing patients with education and appropriate referral for weight management will decrease our obesity rates in the U.S., therefore decreasing patients' risk factors for heart disease, diabetes, stroke, etc. So more than 60% of these patients are not receiving education or referral on weight management. So there is still significant room for improvement on following these guidelines. So based on these results, it is important for healthcare providers to be mindful of these guidelines set in place and to start educating these patients diagnosed with obesity. And these are my references I used for this research. Thank you.
Hello, my name is Stephanie Gage, and I'm in the FNP program here at Arkansas State University. My research project is comparing the efficacy of intra-articular leukocyte-rich to leukocyte-poor platelet-rich plasma injections to intra-articular corticosteroid injections in treating knee osteoarthritis. I would like to take a moment to thank my faculty mentor, Dr. Chris Jordan, and my clinical instructor, Dr. Nancy Baltz, for their assistance with this research project. Here I've included my Create a State research poster. In the following slides, I will go through each section in more detail. In 2019, the Centers for Disease Control and Prevention estimated that over 30 million adults in the U.S. have been diagnosed with knee osteoarthritis. This is a map from the CDC showing that in 2015, Arkansas was listed as one of the top 15 states for adults being diagnosed with knee osteoarthritis, with 34 to 46% of the state's population being affected. Knee osteoarthritis is a chronic, progressive degeneration of articular cartilage leading to joint space narrowing, thereby producing pain, limited range of motion, and stiffness, which negatively impacts patients' functional abilities and quality of life. This illustration shows a normal knee joint here on the left. You can see adequate joint space, and the articular cartilage is nice and smooth. On the right is what an arthritic knee might look like. You can see joint space narrowing and cartilage loss, and several areas of bone spur formation. So you can see why patients with knee osteoarthritis have problems really doing any activities. Intra-articular corticosteroid injections have long been a standard treatment for knee osteoarthritis. However, their often and prolonged use has been shown to progress cartilage deterioration. Recently, a new treatment option has been introduced, platelet-rich plasma or PRP intra-articular injections. There are currently two subtypes of PRP, either leukocyte-rich or leukocyte-poor. However, it remains unclear which is more effective in reducing osteoarthritis symptoms. The purpose of this study is to determine which PRP injection is more effective in pain reduction for the treatment of knee osteoarthritis when compared to corticosteroid. The primary objective of the study is to determine which PRP injection is more effective at reducing pain caused by knee osteoarthritis when compared to intra-articular corticosteroid injection. If we reveal which PRP is more effective at reducing knee pain, we can then compare the efficacy to corticosteroid injections to determine if PRP would be a safer, more effective treatment option. The charts reviewed in this study included both male and female patients with ICD-10 codes of M17.11 or M17.12 who were between the ages of 40 and 60 years old with commercial health insurance and visited the clinic between the dates of November 1st, 2018 to November 1st, 2019 and received either leukocyte-rich or leukocyte-poor PRP or corticosteroid knee injections. Exclusion criteria included those under the age of 40 and over the age of 60 without commercial health insurance and lacking the ICD-10 codes of M17.11 or M17.12. A total of 30 patients were included in this retrospective chart review. You can see in the leukocyte-rich PRP group, there were 10 patients, all of which were male. In the leukocyte-poor PRP group, there were 4 patients, 2 male and 2 female. And in the corticosteroid group, there were 16 patients, 6 male and 10 female. This descriptive study was conducted at a local Arkansas orthopedic clinic through a retrospective chart review of 30 electronic medical records. Simple mathematical calculations were utilized to determine which type of PRP injection was more effective at improving knee osteoarthritis symptoms when compared to corticosteroid knee injection. This graph demonstrates the breakdown of the degree of osteoarthritis our patients were diagnosed with. As you can see, the majority of our patients were diagnosed with severe knee osteoarthritis. 10 patients were diagnosed with mild osteoarthritis, and only 3 patients were diagnosed with moderate osteoarthritis. This study found that leukocyte-poor PRP injections appeared to obtain better pain relief than leukocyte-rich PRP injections, having a 100% success rate. As you can see from the chart, corticosteroid injections also had a 100% success rate in relieving knee pain. Of those that received leukocyte-rich PRP, 70% achieved pain relief, while the other 30% did not and subsequently underwent joint replacement surgery. An interesting note, age did not seem to be a contributing factor in determining the amount of relief obtained from either PRP or corticosteroid injection, as the patients that resulted in joint replacement were 48, 50, and 53 years old, all of which had severe knee osteoarthritis. The number of adults dealing with knee osteoarthritis is substantial, putting significant pressure on our healthcare system. It is estimated that $140 billion is spent each year on direct medical costs related to knee osteoarthritis. Numerous research studies have proven PRP injections to be a safer option when compared to corticosteroid, as the product of PRP is autologous and causes no adverse effects, whereas repeated corticosteroid injections within a 3-month period can lead to progressive cartilage degeneration. In efforts to find safe, successful, and cost-effective treatment options for knee osteoarthritis, this chart review found leukocyte-poor PRP injections to be as effective at relieving osteoarthritis-associated joint pain as corticosteroid injections. I recommend further research into comparing the efficacy of PRP injections in the treatment of knee osteoarthritis, preferably with a larger sample population to obtain more accurate results. Here are just a few references from my research project. If you would like a full list of my references, those are available upon request.
The value of ankle brachial index screening in high-risk patients with atherosclerosis. Introduction. Atherosclerosis is a condition in which plaque builds upon the vessel walls, resulting in narrowing and reduction in blood flow. Peripheral artery disease, PAD, is a form of atherosclerosis that can affect any vessel in your body, but often affects the vessels of the lower extremities. Peripheral artery disease affects 8.5 million people in the U.S., with 12 to 20% being older than age 60. The ankle brachial index screening is useful in determining if vessels are narrowed to the point of needing treatment, such as lifestyle modifications, medications, or referral to a vascular surgeon. Purpose. The primary purpose of this study is to determine if the ankle brachial index screening is being used as recommended by the American College of Cardiology and the American Heart Association as a successful predictor for early identification of high-risk patients with atherosclerotic disease, specifically PAD, in high-risk patients at a healthcare clinic in Atoka, Tennessee. Methods. Study data was obtained through a randomized chart review of 50 patients who visited a rural Tennessee healthcare clinic between the dates of January 1st, 2019 and November 17th, 2019. Inclusion criteria. Patients 65 plus years of age, patients 50 plus years of age with other atherosclerotic risk factors or a family history of PAD. Adults less than 50 years of age with at least one other atherosclerotic risk factor. Exclusion criteria. All patients previously diagnosed with PAD. Descriptive statistics were used to analyze the results for this study. Population. Data collection includes patients, gender, race, age, ABI scores, and atherosclerotic risk factors. Treatments are based on the ABI result. ABIs of 1.00 to 1.40 are considered normal studies. An ABI of 0.91 to 0.99 is considered borderline blockage, and watchful waiting is indicated. ABIs of 0.41 through 0.90 is considered mild to moderate PAD. That's where you want to begin treatment. ABIs of 0.00 through 0.40 indicate severe PAD, and that's where you want to initiate a vascular consult. Findings. Data from 50 charts revealed 85% of high-risk patients with atherosclerotic risk factors such as smoking, family history of PAD, hypertension, diabetes, hyperlipidemia, obesity, and age greater than 60 were screened with ankle brachial index testing. 76% received treatment interventions such as smoking cessation, weight management education, and hypertension management for ABI scoring of 0.041 to 0.90. 24% of ABI scores were between 0.9 and 1.0, and watchful waiting was indicated. Discussion and action plan. Limitations for the study include a small sample size, data collected from one clinic with one provider, and limited cultural diversity. Implications. The U.S. Preventative Task Force rates ABI screening in asymptomatic adults as an I. This means there is not significant evidence to assess the balance between benefits versus harm, has a lack of proven evidence, and presents conflicting values. The American College of Cardiology and the American Heart Association recommend ABI screening for all adults 65 or older, adults 50 or older with other atherosclerotic risk factors, family history of PAD, and adults less than 50 with at least one other atherosclerotic risk factor. Conclusion. ABI screening is a non-invasive tool, relatively non-expensive, and quick for early detection and prompt intervention for high-risk atherosclerotic patients. This tool can be used in the office setting to determine if education or treatment interventions are needed to prevent cardiovascular events. With on-site results, cardiovascular and cerebral vascular events can be decreased and lives can be saved. In order to treat the high rate of atherosclerosis, an ABI should be considered as a generalized predictor, identifying patients at high risk for developing cardiovascular or cerebral vascular events, and should be incorporated into routine clinical practice.
My name is Jason Gill. I'm a family nurse practitioner student with ASU. My faculty mentors are Dr. Chris Jordan and Ms. Tanya Mead. My quality improvement project is a comparative analysis of influenza vaccination rates among COPD patients aged 60 to 70 years old. The influenza virus is a serious threat to global health, which impacts a multitude of people throughout the world each year. According to the Center for Disease Control, between 291,000 and 646,000 people globally will die from respiratory illnesses that are related to the seasonal flu virus. Much of this population that succumbs to the influenza-related illness has the potential to drastically reduce their mortality outcomes through the utilization of the seasonal influenza vaccination. The seasonal influenza virus is profoundly contagious, and it spreads quickly by means of airborne droplets, which are circulated by coughing and sneezing. In the United States, COPD has ranked the third most common cause of death. COPD has been attributed as a significant cause of both morbidity and mortality, with an immense disease burden considering both primary and secondary care. Persons who live with COPD are especially susceptible to devastating outcomes produced by the seasonal influenza virus. The flu is one of the most common viral pathogens that are responsible for the exacerbation of COPD-related illnesses. While COPD is not a curable disease, it is treatable while keeping exacerbations to a minimum. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD, advocates that the COPD patients receive their annual influenza vaccine. This is because seasonal vaccination of this population has been shown to have positive outcomes in reducing COPD exacerbations, hospitalizations, and mortality events. In addition to the GOLD recommendations, the vaccination among COPD patients, Healthy People 2020 has also set a goal for vaccination among this high-risk population, such as those with COPD. The goal of compliance among the COPD population is 90%. The vaccination rate for this population, though, however, is only 41% compliance. Previous research has demonstrated a high prevalence of the influenza virus among the COPD patients experiencing an exacerbation, which is likely linked to morbidity and mortality. The purpose of this project is to compare the seasonal influenza vaccination rates of COPD patients at a local clinic in Prairieville, Arkansas, to that of the national average previously discussed, which is approximately 41%. This project uses a quantitative retrospective chart review to obtain information that is relative to the question of interest. Data was gathered at a local clinic in Prairieville, Arkansas, in order to compile the compliance rates of those local COPD patients. It's crucial for healthcare providers to educate and promote seasonal influenza vaccination among high-risk populations, such as those living with COPD, as vaccination has been shown to be beneficial among this population. Approval for the project was granted through the Arkansas State University Institutional Review Board and the local clinic administration. Data reported from 21 patients whose matched inclusion criteria of age and ICD-10 code for COPD. The inclusion was that the patient had to be diagnosed with COPD and they were between the ages of 60 and 70 years old, while exclusions, patients who did not have a diagnosis of COPD and those patients who were younger than 60 or older than 70. While considering recommendations by Healthy People 2020, which set the influenza vaccination goal for high-risk patients at 90%, vaccination rates for COPD at this clinic have room for improvement. Based on provided research, annual influenza vaccinations have been shown to reduce the rates of both COPD exacerbations and mortality rates. Clinicians should be aware of the guidelines and recommendations for influenza vaccinations for all patients, but especially for high-risk patients such as those with COPD. Knowledge of risk of reduction of COPD patients through vaccination should be made available through healthcare providers so patient education can be implemented.
Hello, my name is Stephanie Ham. I'm a Master's of Student Nursing, Family Nurse Practitioner student at Arkansas State University College of Nursing and Health Professions. My poster presentation is titled Improving HPV Vaccine Uptake Among Adolescents of HPV Positive Mothers. My mentor is Dr. Christopher Jordan. This slide provides some very important information regarding HPV and the vaccine. However, probably the most significant is that 74% of all HPV-related cancers and 81% of cervical cancers are prevented by the vaccine. While most people don't think HPV is very common, up to 80% of sexually active individuals have had HPV. Currently, there are 7.9 million individuals that are currently infected with HPV, and half of all new infections are boys and girls ages 15 to 24. Human papillomavirus is the most common sexually transmitted disease in the United States and can cause genital warts and many HPV-related cancers. Although the vaccine has been readily available for over 10 years, the United States national average for the HPV vaccine is 43% compared to a coverage rate of 91.1% of the MMR vaccine, which shows that interventions to improve uptake are needed. The objective of this study is to determine how many children age 11 through 15 of HPV-positive mothers have not received the HPV vaccine. IRB was obtained through Arkansas State University, and the study was conducted at a cancer clinic utilizing a retrospective chart review of 50 electronic medical records. A data collection tool was used to gather and transcribe data. Charts reviewed included female patients who visited the clinic between January 1st, 2019 and June 30th, 2019. Data collection included female patients only, their age, race, and HPV positive status. Exclusion criteria included women without HPV positive status or women without children. Results indicated that 74% of children have not received the HPV vaccine, and 26% of children had received the vaccine. Of the 74% of patients with children that had not received the vaccine, 59% of mothers stated they didn't know why their child should receive the vaccine. 24% of mothers stated they did know why their child should receive the vaccine, and 17% of mothers state they have refused the vaccine but were unable to explain why. The HPV vaccine protects against up to 9 high-risk HPV strains. The Advisory Committee on Immunization Practices recommends inclusion of HPV vaccine in the routine childhood vaccination sequence. However, present-day use of the vaccine remains moderately low, indicating that further research is needed to identify the reasons parents are reluctant to vaccinate in order to develop targeted interventions that could possibly increase HPV vaccine uptake among adolescents of HPV-positive mothers.
Hi, my name is Nick Haywood, and I'm a graduate student in the Masters of Athletic Training program here at A-State. I want to start off by saying thank you to everyone who made this research poster happen. My research is on assessment of pre-participation injury risk factors in FBS intercollegiate football players. My mentor is Dr. Scott Bruce, as well as co-author, along with Dr. Robert Bradley and Dr. Carlita Moore. The purpose of this study was to determine if reaction time in both visuomotor and whole body reaction agility were predictors in sustaining lower extremity injuries in players of a Division I Football Bowl Series, or FBS for short. There are approximately 36 injuries that occur for every 1,000 athletic exposures, and a leading cause for this is from poor body mechanics and control. There are prediction models that have examined the role of core muscular endurance and fatigue on musculoskeletal injuries to support this. However, there has been no injury prediction model to date that have looked at a Division I FBS football team. Visuomotor reaction time involves the central and peripheral vision and is the time it takes for a person to visually see a stimulus and the person to react to that stimulus. Whole body reaction agility is essentially the same thing, except the entire body is needed to react and move. In our study, there was a total of 102 Division I players baseline tested during the preseason. In total, there were 7 tests, 3 tests used on a light board, known as the reflection edge, and 4 tests done on a separate device known as the tracer. The reflection edge captured the athlete's visuomotor reaction time on an LED touchscreen light board, and the tracer tested their whole body reaction agility with a monitor and a video camera. The 3 tests used for the reflection edge were Big G, Go No Go, and right and left execution, or RAIL for short. Big G tested true reaction time and accuracy. In Go No Go, the athlete placed their fingers on a home base and were told only to touch their green boxes and not the red boxes. The last test, RAIL, would ask the athlete to touch purple boxes with their right hand and touch yellow boxes with their left hand in order to test right and left hand reaction time. The 4 tracer tests were lateral agility, lateral flanker, diagonal agility, and diagonal flanker. On the monitor, the athlete sees an avatar of themselves and where virtual bumpers appear on the screen, and then have to move to the bumper to make them disappear. The lateral agility test is where the athlete would move to their left or right, depending on where the bumper was, and return to the starting point. The diagonal agility is the same, except they move backwards, right or left diagonally. Both of the flanker tests would have 5 arrows on the top of the screen, and the athlete would move the direction the center arrow was pointing. Sometimes the arrow would be pointing with the other 4, and the other times the arrow would be pointing the opposite way. The athlete would need to see the middle arrow and determine the direction it was pointing before they would disappear on the screen. The flanker tests are similar to the agility tests, except a bumper appears on both sides of the athlete. All of the baseline data from these test batteries were gathered and used to create a prediction model for who is at high risk for musculoskeletal injuries. During the preseason and 12-game regular season, lower extremity musculoskeletal injuries were counted for the model after the season had ended. Linear and logistic regressions reduced the original 102 variables to the final 3-factor prediction model. The multivariable prediction model was derived from a series of analyses for determining relative predictive power of the variables. The interaction effects of the predictors were assessed in 3 ways. The first was graphic representation of the interaction between 2 predictors. The second was combining predictors and examining through a 2x2 cross-tabulation table. And the third was calculating the Mantel-Hansel common odds ratio. Our final 3 factors were big G average reaction time, lateral agility maximum acceleration, and diagonal flanker speed asymmetry. Asymmetry is the difference between the speed going to the right versus going to the left. The optimal cut point via ROC analysis found greater than or equal to 2 predictors, meaning the odds ratio for a player with any combination of the 2 or more predictors had 14 times greater odds of suffering a musculoskeletal injury compared to someone with less than 2 predictors. The clinical relevance of our results demonstrated both whole body reactive agility and visuomotor reaction time are predictors for musculoskeletal injury for Division I football players. We acknowledge the specific factors and their cut points may differ from team to team. This method of data analysis identifies those who are at high risk for injury and allow athletic trainers to implement a remedial program to prevent future injuries. And that is my research poster. I hope all of you enjoyed it, and thank you all for your time.
This is Allison Hitt, an APRN student with the College of Nursing and Health Professions. My study is called An Examination of Referral Rates to Diabetes, Self-Management Education. I want to first start by just giving acknowledgments to Dr. Chris Jordan and also Leah Privet for their guidance and expertise with this project. When looking at diabetes, it's one of the most prevalent chronic diseases in the United States. Each year, 1.5 million people are diagnosed with diabetes. The prevalence rate for diabetes in 2015 was estimated at 30 million Americans. That's 9.4% of the U.S. population. When you look at Arkansas, the rates are even higher at an estimated 12.1%. Diabetes self-management is so important for people with type 2 diabetes. There has been an associated increased use of primary care and preventive services and less frequent use of acute care and inpatient hospital services when patients have diabetes self-management education. Patients who participate in diabetes self-management education are also more likely to follow best practice treatment recommendations, and they have a lowered Medicare claims cost. The purpose of this study is to examine the rates of referrals to diabetes self-management education for male and female patients ages 40 to 65 in a local primary care clinic in Paragould, Arkansas, comparative to the national rate of 5 to 7%. In 2015, the American Diabetes Association, American Association of Diabetes Educators, and Academy of Nutrition and Dietetics issued a joint position statement on the importance of diabetes self-management education in type 2 patients. The position statement included an evidence-based diabetes education algorithm that visually depicts when to refer people with type 2 diabetes to education services. They identified 4 critical times: upon diagnosis, during annual assessment, when a person with diabetes has new complicating factors, and then lastly, upon transitions in care. The findings from our research project. The results of this quality improvement project revealed that in this current clinic setting, 52% of patients with diabetes had a referral in place for education. This equated to 26 out of the 50 charts that were reviewed had a documentation of the referral in place. For the 26, 12 are male patients, 14 were female patients, and the average age of the patients was 60. So when you look at these numbers for this particular clinic, they are much higher than the national average, which is only 5 to 7%. So this clinic did exceptionally well. We would like for them to continue that, and we want to share with other providers some action plans on ways to increase the referral rates, and that's just providing education to the providers as well, letting them know the importance of diabetes self-management for their patients with type 2 diabetes. A marketing plan that focuses on the benefit would also be beneficial. And then if there were more diabetes self-management programs in place. And then lastly, if we were able to use telehealth and more mobile services, this might increase a provider's willingness to make the referral also, and also makes it easier for the patients. Just a few limitations for this study, just that basically it's a very small study, only 50 patient charts were reviewed. It is at a small clinic in rural Arkansas with only 3 providers in the clinic. So that concludes my presentation of an examination of referral rates to diabetes self-management education. Thank you.
Hello everyone, my name is Josh Hodges. I'll be discussing my project, the analysis of adherence to prostate cancer screening guideline within a primary care setting. In the introduction, prostate cancer is the most commonly diagnosed cancer that affects men in the United States, next to skin cancer. Prostate cancer is also the second leading cause of cancer-related deaths in men. Prostate cancer affects men of all ethnicities and socioeconomic backgrounds. The lifetime risk of developing prostate cancer was 16%, and the lifetime risk of death was at 3.4%. There have been different opinions and much confusion surrounding PSA testing for prostate cancer. Therefore, the United States Preventive Task Force, or the USPSTF, created guidelines for PSA screening. Men 70 years of age or older have been given a grade D when it comes to PSA screening. And this grade essentially is meaning that the age group of men are not recommended to have PSA testing due to the high risk of harm over the benefits. And so essentially, PSA can be increased due to a number of things other than prostate cancer, such as prostatitis, UTIs, and BPH. So the issue is, even if one of these illnesses or disease processes cause the elevation of PSA, the provider continues into treatment modalities and begins to implement these. And with this older age group of men, they are at such a higher risk for urinary incontinence, infections, bleeding, and erectile dysfunction after any of the treatment modalities. And the purpose of the study is to compare the rate at which men in the mentioned age group are still being screened, regardless of the current recommendations laid out by the USPSTF. And the objectives, the primary objective of the study is to interpret if a rural clinic in Arkansas is following the best practice recommendations on PSA screening in men 70 years of age or older set out by the USPSTF. Depending on the compliance or lack of the compliance set out by the guideline providers in the clinic may be able to save revenue by not ordering an excessive amount of PSA screenings if it's not indicated. This may also prevent unnecessary harms to the patients due to the risk. And the method used was a retrospective chart review. This study utilized IRB through Arkansas State University, and the study was implemented in a rural family clinic in Paragould, Arkansas. The data was collected through 50 randomly picked charts of the specified population, and the dates were January 1st, 2020 to February 28, 2020. This was the time frame in which the research was conducted. Under a population, the charts were used in the study include male patients, of course, who were 70 years of age or older. The charts were manually searched for the diagnostic test of PSA screening. Females, of course, are a total exclusion criteria, along with men under the age of 70. In the findings, the study showed that the rate of men screened who were not recommended to be screened due to their age was actually 74% at this clinic. The other 26% of men were not screened using PSA, and that actually does follow the USPSTF guidelines. So, under the discussion and action plan here, as far as following the grade D recommendations set forth by the USPSTF on the PSA screening, the clinic in Paragould has quite a bit of room for improvement. The majority of the patient population that was reviewed were being screened unnecessarily, as set forth by the USPSTF. And this may lead to a loss of revenue for the clinic and can cause preventable harms to the patient, which may then incur even more loss of revenue. Provider education and staying current on USPSTF screening recommendations is advised as part of the action plan for this clinic. And of course, education to the patient population as to why we wouldn't screen and why it's not recommended for their age group. And then, of course, a discussion about the harms versus benefits for the screening. And as far as acknowledgments, I'd like to acknowledge Dr. Foster and Ms. Hadley, and have references available upon request. Thank you.
Hello, my name is David Hoffman. A little background about myself. I am doing my poster project on obesity screenings. I am a student in the Master of Science Nursing program, the Family Nurse Practitioner program. The background about myself is I have actually been obese in the past. I have lost over 100 pounds, so obesity is it's a concern to me as it involves the healthcare setting. So I want to do my research on obesity itself. So my project is going to be examining the rate of obesity screenings in a primary care clinic comparative to the national average. This was done in a primary care clinic in the area. The purpose of it, the introduction to it, the obesity, it's a global pandemic. The rates of obesity have nearly tripled since 1975 over roughly a 40 to 50 year period. With this creates a lot of healthcare related costs. They've increased 187% between 1998 and 2008. This trend continues to increase. In the year 2018, 31.3% of Americans were obese. This is obesity considering a BMI or over 30. Preventive medicine is coming to the forefront of healthcare, and this is one of the trends to prevent obesity, in my opinion. So one of the first things you do to prevent in preventive medicine is recognizing the problem. Preventive medicine is showing great promise in combating the pandemic. A goal was set by the Healthy People 2020 initiative for 53.6% of patients in the family care setting to be screened for obesity. This is the national average we're going to be comparing the rural clinic with. The purpose with my research is to discover the incidence of primary care providers in the Rural Arkansas Clinic who regularly assess BMI in their adult patients compared with this Healthy People 2020 initiative. The objective was to ascertain the rate of obesity screenings in this local clinic and compare that with the national average again. The methods I used to get this, the IRB, was obtained through Arkansas State University. It was a retrospective chart study. The data I gathered for this chart study was between the months of January 1, 2019 and June 30 of 2019. Through this time, 2,239 patient charts were reviewed via the clinic's electronic health record. That's the data collection tool that was used. The population of the patients were, again, 2,239 for the total number. All patients seen over the age of 18. We excluded anyone under the age of 18. We included, again, all over 18, male, female, irrespective of race. The findings of the study was, per their EHR, which is again their electronic health record, 93.08% of the patients that were seen in the clinic through those 6 months were adequately screened for both overweight and obesity per their BMI. So the discussion around this, there's many barriers to BMI screenings in the past, but EHRs and EMRs are becoming widely used. And with the introduction of these in the clinic setting, I do feel that the Healthy People 2020 initiative will be met as it was met in this rural clinic. Using this data, we can ascertain an increasing ability in not only screening for patients for obesity, but also educating and treating for the disease itself. Again, screening and recognizing the problem is the first step to treating this problem and getting ahead of this problem. The references I used for this particular slide are the Healthy People 2020 initiative, which is the NWS 5-1 initiative for 2019, the World Health Organization obesity and overweight article from their online database, and the United Health Foundation obesity in Arkansas in 2018 information. I would like to acknowledge in this the Family Practice Clinic of Paragould, Arkansas, specifically Ronette Wise, nurse practitioner, my preceptor, and Ginger Hyde, the office manager. I'd also like to recognize Dr. Chris Jordan, who is my faculty advisor in this, and Dr. Savannah Coyne, which is my clinical instructor throughout my clinicals. I hope you enjoy the presentation. Thank you very much.
Hello everyone, my name is Lauren Huff, and today I'm going to be reviewing the analysis of a local clinic's compliance rate for screening for type 2 diabetes. The leading cause of death globally is cardiovascular disease. Associated risk factors with cardiovascular disease include obesity, smoking, hypertension, diabetes, and hyperlipidemia. These risk factors are modifiable. Diabetes affects approximately 30 million people, or 9.4% of the United States population. Of these 30 million individuals that are affected, an estimated 7.2 million have not been diagnosed. Obesity affects 1 in 3 adults, and as we mentioned earlier, is a modifiable risk factor associated with cardiovascular disease, along with diabetes. It is currently recommended that patients that are obese are being screened for type 2 diabetes by their primary care provider with a hemoglobin A1C, a glucose tolerance test, or a fasting blood glucose level. Screening for the population is recommended by the United States Preventative Task Force for patients that are between the ages of 45 to 70 years of age and that are also obese. The purpose of this study was to determine the compliance rate of screening for type 2 diabetes according to the U.S. Preventative Task Force recommendation in a rural primary clinic located in Forest City, Arkansas. The primary objective of this study, once again, is to determine the compliance rate of completing a screening for type 2 diabetes via an A1C reading in a rural primary clinic. Analyzing the clinician's screening compliance rate will allow for practice changes by the clinician to improve screening rates if needed. As these screening rates are improved, the overall health outcomes of the patient population will benefit. In completing this analysis, an IRB was obtained through Arkansas State University. The study was conducted using a retrospective chart audit, and this chart audit included 50 charts that were reviewed through an EMR in the primary clinic. The total population seen between September 1st and November 1st of 2019 was analyzed. The data collected included age, sex, race, current BMI, and if the screening had been completed. Sample population information. The inclusion criteria for this analysis included male and female patients that were between the ages of 45 to 70 years of age, that also had a diagnosis of obesity and had a procedure code for an A1C screening completion. Exclusion criteria for the sample population were those patients that were less than 45 years of age or older than 70 years of age. If the patient already had a diagnosis of diabetes, they were not included in the analysis, and patients that did not have a diagnosis of obesity listed were not included in the data analysis. In completing the data analysis of the 50 charts reviewed, 38% of this patient population had an A1C screening completed. This rate of screening is lower than the rate that was analyzed by the United States Preventative Task Force. That rate was at 50%. The findings of this analysis show that there is room for improvement in the screening rate at this local rural clinic. As clinicians increase the screening rate, early diagnosis can be made. An earlier diagnosis leads to earlier education, improved health outcomes for the patient, and a decrease in the overall cost of health care. An interesting fact that I was able to note in reviewing the data analysis was as these screenings were completed in the 50 charts I reviewed, those that had an A1C completed were able to have a new diagnosis noted in 4 patients. Once again, as an earlier diagnosis is completed, the patient is able to have earlier referrals for a diabetic educator, podiatry if needed, and endocrinologist to assist and collaborate with the primary health care provider in managing these patients with a type 2 diabetes diagnosis. Thank you.
Hello everybody, my name is Colt Huggins and I will be talking about the effects of myofascial release on respiratory muscle function. So myofascial release is a hands-on technique that involves a low load or gentle pressure through skin-to-skin contact that causes changes to viscoelastic mediums such as the fascial system of our bodies. Myofascial release has been shown to be a safe and effective technique to address connective tissue restrictions in order to eliminate pain and restore motion. Why did we focus on respiratory muscle function? Well, that's because research has shown that there is a correlation with back pain and pulmonary conditions. We wanted to understand more about the effects myofascial release has on the diaphragm in hopes of finding implications for hands-on interventions that address the anatomical problem instead of medication that addresses the symptoms alone. Since there is currently limited research of myofascial release on the diaphragm, we decided to see effects of it on healthy individuals prior to looking at people with pulmonary pathologies. So, we wanted to find a few things: anatomical change and functional change. We wanted to determine the effects the release had on the diaphragm using ultrasound. We also wanted to determine the effect that it had on your functional respiratory measurement. So how did we do it? We gathered healthy subjects aged 20 to 30, healthy meaning no back pain and no previous diagnosis of pulmonary pathologies such as COPD or emphysema, asthma, things like that. Functional capacity was measured with COSMED equipment to obtain forced vital capacity and forced expiratory volume. These objective measurements are indicators of pulmonary pathology and used to diagnose things such as COPD and asthma. Anatomical changes were measured with ultrasound images obtained with 4 MHz curvilinear array transducer that allows for greater sound wave penetration. Diaphragm excursion as well as the width were obtained. These measurements were taken 3 times, once at the baseline, once after deep breathing technique, and once after the myofascial release itself. So what did we find? Based on an alpha level of 0.05, the only significant difference on the within subjects factor was the FEV1 FVC ratio, so the forced expiratory volume ratio to the forced vital capacity. No changes were noted in the FEV1 alone, FVC, or no anatomical changes were noted. So what does this mean? Myofascial release, as described earlier, is used to address restrictions in the myofascial system. As we measured healthy subjects, we did not expect to see much anatomical change, if any, because they had no impairments to begin with. The decrease in the FEV1 FVC ratio does denote a decline in pulmonary function. However, we believe that this decline is likely secondary to exhaustion, as repeated testing was performed in a single session rather than 3 separate sessions. Further research is needed to determine these unknowns. First, we need to adjust protocol to identify if the exhaustion was in fact the cause. And second, we need to perform research on individuals with anatomical or fascial restrictions to determine the effectiveness of this release technique. To end, I just want to mention that Miss Deanna Berryman was our sonographer who was in control of everything with obtaining all the measurements that we had from the ultrasound, and her name is not on this poster, so I don't know why, but she was a big help in this research. Thank you.
Hello, my name is Casey Johnson, and I'm currently a student in the MSN FNP program, presenting today the examination of pediatric blood level screening rates in the primary care setting. Here's the complete poster view of what we're going to be discussing today. Let's take a few moments and discuss the individual categories and their importance. Lead exposure at any age can cause long-lasting negative effects for those exposed. The pediatric population is particularly at high risk for lead level exposure and toxicity due to the developmental stages that they're obtaining at the time. The pediatric cohort for this is 12 months to 6 years of age. With their developing mind, they are at high risk for irreversible neurological damage in both acute and chronic lead exposures, which can lead to development of ADHD, ADD, decreased brain volume as an adult, poor academic performance, and increased risk of criminal behavior as an adult. For ADD and ADHD, 1 out of every 5 childhood diagnoses of ADHD is directly related to lead level exposure. And according to the American Academy of Pediatrics, children in this cohort
have lost approximately 23 million IQ points due to lead level exposure. The lead level exposure that causes these different neurological deficits are those that are 5 micrograms per deciliter or greater, according to the CDC. The American Academy of Pediatrics states that approximately 2.6% of children aged 1 to 5 years have a blood level higher than the reference lab, which equates to 535,000 children. Common sources of lead exposures include contaminated water supply, household paint, pottery with lead glaze, herbal remedies, imported cosmetics, and imported candies. For the contaminated water supply, that's the drinking water lines that are coming into your home. The importance of having those removed or having lines made of different substances was very evident in the Flint water crisis. During that time, their lines are primarily made up of lead, and the exposure rate was increased by 36% in the pediatric population. For household paint over the last 4 decades, we've made major strides in decreasing the concentration of lead in those paints, therefore decreasing the exposure risk. The concentration of paint has been reduced to 90 parts per million, and that has been since 1978. And that's why when you go for a house, that's something that has to be expressed if the home has had their paint tested, if the home is older or built before 1978. As well as we have unleaded our gasoline. To mitigate these risks and identify exposures, the CDC has passed guidelines to govern the screening intervals at 12 months, 24 months, and at least one time before they're 6 years of age if not previously screened. Children, however, that are receiving Medicaid benefits are mandated to obtain this at 12 months and 24 months and at least one time before they're 6 years old. The objective of this study was to examine in the primary care setting if pediatric patients less than 6 years of age, if they're obtaining the blood level screenings in comparison to the national screening average of 18.7%. The method used for this study was a quantitative retrospective chart review. The chart review is focused on the following ICD-10 codes: ICD-10 Z13.88, R78.71, a CPT code of 83655, and CPT of 36416. The inclusion criteria for this study consisted of 50 pediatric patients. They were aged 12 months to 6 years old. 25 of the charts had to have listed their primary insurance as Medicaid or RKids, and the other 25 charts were listed as their primary insurance as commercial or private pay. Exclusion criteria for this study was any child over 6 years of age. The findings for this study in this particular primary care clinic, the screening rate for Medicaid patients that met inclusion criteria was 0%. The screening rate for commercial, insured, and private pay pediatric patients was 0%. The national average screening rate is 18.7%. Arkansas does not mandate universal screening for all patients within the cohort through formal regulations. Arkansas only requires screening to be in compliance with Medicaid requirements. However, it does not mandate reporting for screening compliance to the CDC. For an action plan following this study would be a study that evaluates for obstacles hindering compliance, and provider opinions over the blood level screening is suggested. According to Deloy, Marquez, and Gernsberg, compliance rates of physicians surveyed within their study only indicated 40% compliant with the CDC recommendations. Obstacles that they stated was by the physicians was confusion over the different recommendations, lack of state mandate, and belief that screening for asymptomatic patients is not needed. Physicians that possessed a high compliance rate stated it directly relates to parent-patient education, in-house screening, and staying cognizant of the current recommendations. I'd like to take this time to acknowledge the work of Dr. Chris Jordan, my mentor through Arkansas State University, as well as Ms. Leah Privet, my clinical instructor at Arkansas State University, for their hard work and dedication. References are as listed. Thank you for your time.
Hi, my name is Emily Johnson, and I'm an FNP student at Arkansas State University. The title of my quality improvement project is Statin Therapy Use in High-Risk Patients, and at this time, I would like to acknowledge my mentor and clinical instructor, Ms. Tammy Bell, APRN. Heart disease is the #1 cause of death in the United States, and coronary heart disease is the most common type according to the Centers for Disease Control and Prevention. The statin class of medications has proven to decrease the risk of cardiovascular-related deaths. Approximately for every 40 milligrams per deciliter that the LDL is reduced with statin therapy, the major risk of cardiovascular-related events is reduced by about 20 to 25%, and all-cause mortality is reduced by about 10% according to the American College of Cardiology. The current recommendation by the United States Preventive Services Task Force states, adults age 40 to 75 years with no history of cardiovascular disease, one or more risk factors, and a calculated 10-year CVD risk of 10% or greater should take a low to moderate dose statin to prevent cardiovascular-related events and decrease mortality. The purpose of this quality improvement project is to assess the rate of male and female adult patients aged 40 to 75 years old who are both eligible for and receiving statin therapy in a local clinic based on the task force recommendations for statin therapy as prevention of cardiovascular disease and related events. The objective of this study is to observe the rate of patients aged 40 to 75 years old with a cardiovascular disease risk greater than or equal to 10% of patients who receive statin therapy in a local clinic as recommended by the United States Task Force. This retrospective chart review occurred in a rural primary clinic in northeastern Arkansas. 50 charts were reviewed from January 1st, 2019 to November 18, 2019. The data was collected and simple percentages were used as a statistical analysis method. This is a picture of the American Heart Association risk calculator that was used in this study to individualize each patient's 10-year cardiovascular disease risk. It takes under consideration if the patient was a smoker, if the patient is on hypertensive treatment, the patient's blood pressure, if the patient was on a statin, if the patient has diabetes, as well as the patient's individual cholesterol readings. These charts included a randomized sample of patients aged 40 through 75 with no history of cardiovascular disease and one or more CVD risk factors, such as dyslipidemia, diabetes, hypertension, or smoking. Patients less than 40 and greater than 75 were excluded from this study. Patients with a history of coronary heart disease or cerebrovascular disease were excluded from the study as well, and the ICD codes are shown that correlate with each of these. As a result, 64% of patients that were eligible for statin therapy were on a statin drug. After reviewing patients' charts, it was found that out of 18 patients who were not on a statin, 10 of those declined. There were 3 of those 10 who stated they did not tolerate this class of medications. There were 7 patients with no known documentation of the exclusion of statin therapy in the patient's plan of care. 1 patient that was not on a statin drug had chronic hepatitis C with elevated liver enzymes. And one weakness of this study is I should have excluded any patient with active liver disease as it is contraindicated to prescribe a statin drug with a patient who has active liver disease. 2 of the patients who were not on a statin drug opted out to take red yeast rice. This is a percentage of statin-eligible United States adults currently taking statin therapy. As we can see, in 2011 to 2012, in the United States, there were 29.8% of patients that were eligible and taking statin therapy. This slightly increased from 2013 to 2014 to 30.3%. My clinic's percentage of 64% is significantly higher than the United States, but we do have to take under consideration that this comparison used the 7.5% as the minimum risk factor to prescribe statin therapy, and for my project, I used the United States Task Force of 10% as the minimum risk factor to prescribe statin therapy. Although my clinic's statin therapy percentage is probably higher than average, the results of this study can be used to recognize a need for this clinic to focus on techniques to increase statin therapy compliance. The results of this study showed that most patients refuse a statin therapy due to intolerable side effects, and 55.56% of patients declined a statin due to these intolerable side effects. And as many studies have shown, intolerable side effects is one barrier to prescribing statin therapy and decreasing cardiovascular-related events and deaths. My action plan to decrease barriers to statin therapy compliance include to identify each patient individual issue and work with them to develop a plan of care that works best for them. We also need to utilize statin intolerance calculators as well as the AHA risk calculator. We need to reduce the dose or change medications. Some statin drugs will stay in the system longer than others, so if we change the statin drug, we might decrease their symptoms, as well as if the patient can take the medication at least once every other day or once weekly, they will still see a benefit from that medication. We need to simplify the patient's medication list as much as possible. We need to remind patients to take their medications, and we need to show them the laboratory results and that what they're doing and their hard work is paying off. We also need to take each individual's educational background in consideration when trying to attempt to teach these patients. These are my references, and that concludes my quality improvement project. Thank you very much.
Depression screenings in a rural primary care clinic compared to the national average, presented by Tabitha Johnson, mentor Lauren Hancock. This is the overall completed poster presentation. Introduction and purpose. Depression is a significant healthcare issue. Major depressive disorder or clinical depression are other terms commonly used for depression. Depression is characterized by sadness, loss of energy, loss of interest in activities, difficulty sleeping, appetite changes, difficulty thinking, or even thoughts of taking one's own life. Undiagnosed or untreated depression can lead to severe problems and adverse outcomes such as alcohol or drug addiction, quitting work or getting fired, physical health complications, or even harm to oneself or suicide. It is essential to diagnose and treat depression to reduce these problems and establish positive outcomes. Depression can affect anyone, but it is more common in women than men. Depression is the most treatable mental illness. Most people affected by depression can gain improvement and overcome symptoms with the correct diagnosis and appropriate treatment. Genetics, personality, biochemistry, and environmental factors all play a role in the chances of depression. Serious medical illness, trauma, or drugs or alcohol abuse can also increase the incidence of depression. Depression is treated with medications or psychotherapy, also known as talk therapy, or a combination of both. Objectives. The purpose of this study is to determine the number of patients over 21 years old in which a depression screening tool is being effectively used to evaluate the need for treatment yearly in a family practice clinic. By determining the amount of depression screenings conducted in this clinic, it will bring awareness to the providers and help monitor the need for improvement or how well they are doing compared to the national average. This study is beneficial in identifying the need for depression screenings and improving patient outcomes. Methods. IRB was obtained through Arkansas State University. A retrospective chart review was conducted using 50 random charts from January 2018 through January 2019. Mathematical equations were used to determine the percentage of patients in which a depression screening was conducted during this time. The percentage determined was compared to the national average of 4.2%. Population. This retrospective chart review included age, gender, and race. Charts reviewed included patients 21 years of age or older. No exclusions to race were identified. Male and female patients were both reviewed. Exclusions to the study were charts with the ICD-10 code of F79, intellectual disabilities, and F33, depressive disorder. No charts reviewed were under the age of 21. Findings. Data analysis of the 50 charts reviewed revealed a percentage of 16% of patients were screened for depression in this rural clinic in Arkansas. Even though this percentage is low, it is significantly higher than the national average of 4.2%. The average age of the patients in this study were 46 years old. Of the patients screened in this review, only 6 were males and all were Caucasian. Discussion and plan. In 2016, the U.S. Preventative Task Force established recommendations stating the general adult population should be screened for depression to accurately establish diagnosis, treatment, and follow-up. Despite these recommendations, screenings are low and a need for improvement is indicated. Bringing awareness to the need for depression screenings will greatly improve utilization of screenings and overall patient outcomes with depression. Increasing awareness is the first step. Acknowledgements. Mentor Lauren Hancock. References on request. Thank you for listening to this presentation.
Hi, my name is Clara Jones, and the title of my project is A Local Clinic's HCV Screening Rate for Patients Born During the Years 1945 through 1965. Before we get started, I would like to take a second to thank my mentor, Dr. Christopher Jordan, for his guidance during this project. So what is hepatitis C? Hepatitis C is defined as a systemic viral infection that can be acute or chronic, primarily involving the liver, caused by hepatitis C virus, or HCV. It is estimated that 3 million individuals in the United States are currently living with hepatitis C infection, making it the most common bloodborne pathogen in the U.S. Of these 3 million individuals, studies show that 45 to 85% are unaware of the infection. It only takes about 6 months for acute hepatitis C to develop into chronic hepatitis C. And chronic hepatitis C is the #1 cause of chronic liver disease and liver transplants in the United States. On a state level, it is predicted that 38,000 Arkansans are currently infected with the HCV virus. Before 2013, providers screened patients for hepatitis C by utilizing the risk-based screening guidelines. These guidelines are listed on the slide. It is said that screening based on these guidelines is missing 49 to 75% of the hepatitis C infections in the United States. Because of these statistics, the United States Preventative Services Task Force released a statement saying, the USPSTF also recommends offering a one-time screening for hepatitis C infections to adults born between 1945 and 1965. These are considered the baby boomers of our time. It is estimated that adding a birth cohort screening will find over 800,000 new cases of a hepatitis C infection. Early detection of hepatitis C could save patients a lot of money in the long run. For example, a 12-week treatment for hepatitis C can range from a one-time cost of $66,000 to $95,000. In contrast, end-stage liver disease costs the patient $4,900 a month, or approximately $60,000 a year indefinitely. The purpose of the study is to compare the screening rates for hepatitis C virus in male and female patients born within the years 1945 to 1965 in the local clinic to the national average hepatitis C screening rate of 12.8% for female and male patients born within the years 1945 to 1965. IRB approval was obtained through Arkansas State University. A retrospective chart review of 100 charts was conducted. Data was collected from a primary care clinic in Paragould, Arkansas. Data included birth year, age, gender, if the patient had been screened for HCV, and if the patient was screened based on risk factors. My inclusion criteria was born during the years 1945 to 1965 and visited the clinic between January 1st, 2019 and May 31st, 2019. Exclusion criteria was born earlier than 1945 or later than 1965, and if a hepatitis panel was performed. Results showed that 44% of the patients that visited the clinic between January 1st, 2019 and May 31st, 2019 were screened for hepatitis C. 40% of those patients were screened based solely on birth cohort. These results greatly exceed the national screening average. Here's just a chart showing how the clinic screened 40% of their patients compared to 12.8% of the national average. Each provider at the clinic also exceeded the national screening average. Provider number 1 screened 28.9%, provider number 2 screened 53.5%, and provider number 3 screened 40.6%, all of which are greatly increased compared to the national screening average of 12.8%. The ultimate goal is to screen 100% of baby boomers. This would allow us to detect hepatitis C infections in the earlier stages and start appropriate courses of treatment. In return, this will decrease the amount of end-stage liver disease and liver transplants due to hepatitis C infections. After discussing the results with the providers, we concluded that best practice alerts improve hepatitis C screening rates in the 1945 to 1965 birth cohort. We also discussed further education to solidify provider knowledge of hepatitis C. This further education will create a confidence when discussing why a patient needs HCV testing, instead of just saying it is recommended. I would like to thank you all for taking the time to listen to my project. I hope I have provided insight into the importance of birth cohort screening along with risk-based screening for hepatitis C. Again, thank you for your time.
Hi, my name is Erica Jordan, and I'm a nurse practitioner student with Arkansas State University. I did my project on if the influenza vaccine was effective in the prevention of influenza infection. I did this study beginning in spring of 2018 at my clinical rotation in a local rural medical clinic. It was a minor med. We saw in the uppers of 150 patients a day, most of them due to the rural area of farming and the seasonal allergies and things like that. The majority of the patients seen daily had symptoms flu-like symptoms, and therefore each and every one of them were tested. And a common question was, have you had the flu vaccine within the year? I noticed that everyone who said yes were testing negative. So I decided to do a chart audit and determine, is the vaccine truly that effective against the virus? Many of the patients who did test positive did not receive the influenza vaccine. During the study, only about 7 to 8% did. Some of the influence that also led me to do this project was to determine the negative stigmatism of the vaccine, determining if the vaccine does actually make you sick, and if it exposes you to the flu, even with the vast evidence that it doesn't. And the overall goal of my study is to provide a local level statistical rate of effectiveness of the influenza vaccine compared to the national average. So if you had the vaccine and you tested positive or negative, how much coverage are you having compared to our national coverage that was reported by the CDC? Some of the primary objectives of the study was to determine if the patients who visited the clinic with influenza-like symptoms would test positive while receiving the vaccine. I also wanted to determine, is our patients in this local area comparative to the national average on coverage for the influenza vaccine? The test was conducted from November of 2018 to November 2019. I used the IRB for my submission study, and I used a descriptive study of a rural Arkansas minor med clinic, and it was a retrospective chart review of 50 electric medical records. A percentage was determined based on patients who presented to the clinic with flu-like symptoms but tested negative and received the influenza vaccine within the current year. The population that was included in the study was all males and females from ages 6 months and up. The CDC recommends that anybody 6 months and up should be vaccinated for the influenza yearly. So if you meet that criteria, you're included. The one exclusion for the project was the severely immunocompromised patients. Some of them are able to get the vaccine, some are not. The ones who can't usually have everybody around them vaccinate themselves to help protect them. So due to the complexity of their illnesses, they were excluded. But anybody else was included. Comorbidities other than the extremely immunocompromised were included. So 50 charts were audited. If you came into the facility with flu-like symptoms, and if you've had the shot, you were included. Of the 50 patients who came to the clinic during this time period with flu-like symptoms who received the influenza vaccine, 46 of them tested negative. Of the 50 patients, only 4 of the patients tested positive. That makes the effectiveness rate for the influenza vaccine for our local area 92% effective for that year. The CDC reported that during the 2018-2019 year, 95% covered from the virus with the influenza vaccine. So we have a differential rate of about 3%, regardless of the 95 or 92. When you reach a 90% or higher coverage rate, it is worth the shot. I will use this for a future discussion plan to determine and help local patients and providers use this in the Northeast Arkansas areas to show that the coverage of the vaccine far outweighs the risk and benefits of the virus. And it can be used as a continued discussion, education, and action plan to increase vaccine rates, which will indeed lower mortality and sickness rates. I would like to give my acknowledgments to Dr. Nancy Baltz, my clinical instructor, and Dr. Mark Foster, the director of the Family Nurse Practitioner Program, and references are available upon request.
Hello, my name is Jenny Keller. I'm a family nurse practitioner graduate student at the College of Nursing and Health Profession at Arkansas State University. I would like to acknowledge my faculty mentors, Dr. Chris Jordan, clinical advisor, and Tammy Bell, clinical instructor. This is my Create A State presentation on an examination of alcohol screening within a family practice setting. I'm going to begin with some alarming statistical data. The use of excessive alcohol is the third leading preventable death in the United States, according to the CDC. It is the leading cause of premature mortality, accounting for 1 in 10 deaths among working age adults in the United States. It is the fifth leading risk factor for premature death and disability in 2010. The cost of alcohol misuse carried a U.S. economic burden of approximately $249 billion in 2010. Some definitions I'd like to review. Unhealthy alcohol use defines a spectrum of behaviors to include risky drinking, alcohol use disorder, harmful alcohol use, abuse, or dependence. Alcohol use disorder attributed to 3.3 million deaths globally in 2010, with over 200 associated conditions, including chronic illnesses such as cardiomyopathy, hypertension, hepatitis, pancreatitis, stroke, esophageal varices, and gastritis. Some other alcohol-related acute deaths include motor vehicle accidents, drownings, child maltreatment, homicide, suicide, firearm-related fires, and poisonings. In 2001 alone, there were an estimated 2.3 million years of potential life lost due to excessive use of alcohol. To break down on a visual pie chart, government spending was accounted for $100.7 billion. Binge drinking, $191 billion. Underage drinking, $24.3 billion. And drinking during pregnancy, $5.5 billion. The United States Preventative Task Force recommends screening for unhealthy alcohol use in primary care settings in adults 18 years or older. This is now the standard for family providers. The purpose of this study is to identify the percentage rate of alcohol screening performed in adults 18 years or older in a family practice clinic in Northeast Arkansas. The population, after the IRB was accepted through Arkansas State University and a letter of approval was received from the clinical director. The clinic electronic medical record program randomly selected 50 charts. A non-research retrospective chart review was performed. The patient's social history was reviewed and each file to determine if the alcohol use screening question was documented yes or no. Inclusion criteria was established patient at the multi-provider clinic. Age 18 years of age or older, male or female. The exclusion was under the age of 18 years of age. This clinic received an A+ because the results found that 94% of the charts reviewed had been screened for the use of alcohol. The United States Preventative Task Force has found adequate evidence that screening and providing brief intervention and referral to treatment has found to reduce alcohol consumption by an average of 17%. Some vital influences of this project include increasing knowledge, awareness, and importance of alcohol screening in the primary care setting to improve patient health care outcomes and decrease mortality rates. Globally, there's limited studies performed regarding the use of this. With the guidance and assistance of government agencies, public health and healthcare providers, a significant impact of the detrimental effects of alcohol misuse can be made. This concludes my presentation.
Hi, my name is Haley Kennedy,
and I'm an FNP student that will be graduating in May. My research project is over first-line treatment of UTIs in females. I did a retrospective chart review of 58 charts dated from January 2020 to April 2020. The data I collected included the patient's age, antibiotic prescribed, duration, and frequency of treatment. The inclusion criteria involved women between the ages of 18 to 65 who were diagnosed with an uncomplicated UTI. Inappropriate antimicrobial use is linked to antimicrobial resistance. Antimicrobial resistance is predicted to account for 10 million deaths per year globally by 2050. 269 million antibiotics were prescribed to pharmacies for outpatient treatment in 2015. At least 30% of those antibiotics were prescribed unnecessarily, according to the CDC. Urinary tract infections are one of the most common infections in which antibiotics are used to treat. Non-pregnant women with UTI symptoms account for 8 million outpatient visits each year. Drug-resistant organisms have greatly decreased treatment options for infection globally. The best way to combat this crisis is through individual providers, communities striving for evidence-based practice. Guidelines are put into place to promote the best practice, and most uncomplicated UTIs can be treated with first-line treatment effectively. The preferred first-line treatment for uncomplicated UTIs include Macrobid and Bactrim. There is little evidence that shows that Bactrim leads to antimicrobial resistance, therefore it is a good choice for first-line treatment. There are two other first-line treatments that include fosfomycin and pivmakilin. However, fosfomycin is expensive and it is not often used, and pivmakilin is not available in the United States. For the purpose of this study, Macrobid and Bactrim will be considered the two first-line treatment choices. The purpose of this project is to determine how many females with UTIs are treated with first-line treatment in a family practice clinic. So I was hoping to determine the average of inappropriate prescribing of antibiotics for treatment of UTIs in a primary care clinic as compared to the national average of inappropriate antibiotic usage, considering evidence-based guidelines. While the 30% is considering antibiotics for all different kinds of infections, since UTIs account for about 8 million outpatient visits yearly, reduction in the inappropriate use of antibiotics for UTIs would reduce the inappropriate use overall. So my results showed that overall 50% of patients were prescribed first-line treatment and 50% were prescribed other treatment. So 50% of the antibiotics were prescribed inappropriately as compared to the national average of 30%. So there can definitely be some improvement here. The most prescribed antibiotic was Bactrim, which is one of our first-line drugs, so that is good. The next one was Cipro, followed by Macrobid, and then Levaquin and Camplex. So we are on the right track, but we definitely need more awareness. First-line treatment for UTIs is not being adequately utilized in practice, and it should be used to treat uncomplicated UTIs first. Utilization of first-line treatment of UTIs can help reduce antimicrobial resistance, and 50% of patients that presented to the clinic received an inappropriate antibiotic based on clinical guidelines. So that is inadequate. This research revealed that the percentage of inappropriate antibiotic use for UTIs, however, if the rate of inappropriate use of antibiotics for UTIs can be reduced, then the national percentage of the inappropriate antibiotic use would lower as well. Thank you for your time.
Hello everyone, my name is Josh Lammers and I'm a second-year graduate student completing a degree in the Master of Athletic Training program here at Arkansas State. With the help from my mentor, Dr. Scott Bruce, and the other MAT faculty members, Dr. Robert Bradley and Dr. Carlita Moore, we have created a lower extremity injury prediction model for intercollegiate female athletes using visual motor reaction time, abbreviated VMRT, and whole body reactive agility, abbreviated WBRA. Here you can see the full poster that we have created based on the results of the research. The purpose of this research is to assess the relationship between VMRT and WBRA to lower extremity injury rates in high-risk women intercollegiate athletes throughout one season. The findings revealed a three-factor model in which if any athlete had two of the three predictors, she was 9 times more likely to suffer a lower extremity injury than those who did not. Previous research has indicated that it is important for athletes to have good visual motor reaction time and whole body reactive agility in order to avoid injury while participating in their sport. In this study, visual motor reaction time is defined as the time between a stimulus and the reaction to that stimulus, and whole body reactive agility is defined as VMRT applied to whole body movement. "55 intercollegiate women's athletes were baseline tested on their visual motor reaction time and whole body reactive agility before beginning the 2019-2020 season. The study included 23 women's soccer players, 16 women's volleyball players, and 16 women's basketball players from Arkansas State University. Visual motor reaction time and whole body reactive agility were quantified with Reflection Edge and Trazer respectively. Reflection Edge is a 2-foot by 6-foot mounted touchscreen with 2,400 LED lights that athletes react to as quickly and accurately as possible. Trazer is motion sensing technology that tracks player movement and projects it onto a TV screen and requires whole body movement depending on the command given. Athletes completed 3 different Reflection Edge tests to assess visual motor reaction time. The tests were Big G, a test similar to Whack-A-Mole where athletes rapidly touch 30 illuminated squares as they appeared on the board. Go, No Go, a test requiring athletes to touch green lights and avoid red lights. And Rail, a test where athletes would touch purple lights with their right hand and yellow lights with their left hand. Athletes completed 4 different Trazer tests to assess whole body reactive agility. The tests were lateral agility, athletes would move left or right depending on randomly generated directions. Lateral flanker, athletes would move left or right in response to a middle arrow that flashes on the screen. Diagonal agility, similar to lateral agility but at a backwards angle. And diagonal flanker, similar to lateral flanker but at a backwards angle also. Players also filled out a Sports Fitness Index, or SFI, survey, and lower extremity injury was documented throughout the season for each sport. SPSS was used to analyze the data gathered from the baseline test and injury reports. Multi-collinearity analysis reduced the original 102 variables to 41, and logistic regression reduced the 41 to 11 independent variables. Cross-tabulation was used to reduce the number of predictor variables from 11 to 8, and binary logistic regression quantified associations with the predictors to create a 3-factor model. The 3-factor model included BMI SFI question 1, which inquired about players' history of injury leading to limited participation in sport, and rail motor asymmetry. Players who were positive on 2 or more of these factors had 9 times greater odds of injury than those who had less than 2. This evidence reveals that visual motor reaction time and whole body reactive agility can be used to assess which players have a higher risk for lower extremity injury occurrence. Determining the athletes at risk can lead to the remediation and lower extremity injury prevention among women's intercollegiate athletics and can be used as an injury risk factor for athletic trainers working with these athletes. As I conclude, I would like to thank all the athletes who participated to make this study possible, and to thank those who took time out of their day to guide me through the entire process of creating this poster.
Mammogram screening rates for women aged 40 to 49 at a local clinic in Arkansas. Introduction and purpose. Breast cancer screening is an important primary prevention service. 1 in 8 women in the U.S. will be diagnosed with an invasive breast cancer in their lifetime. Mammograms are considered the gold standard for screening because they can detect breast tissue changes before a mass is even palpable, so less than 1 centimeter. Mammograms are also non-invasive and relatively inexpensive. However, guidelines for when a woman should initiate screening are unclear. So the purpose of this study was to see if women falling in a gray area, ages 40 to 49, were choosing to participate in screening mammograms at a local clinic at the rate of the national average. Guidelines. The United States Preventative Task Force recommends yearly screening starting at 50, but women 40 and up can choose to participate. The American College of Obstetricians and Gynecology recommends yearly screenings beginning at 40, while the American Cancer Society says to start screenings yearly at 45 and then biennially screening after 55. But women may also choose to start at 40 if they choose. Methods. The method for the study was a randomized retrospective chart review where a computer selected 100 charts for women ages 40 to 49. The charts were reviewed for screening mammograms for the dates of November 2018 to November 2019. Findings. The data showed only a 16% screening rate at the local clinic, which fell drastically short of the 65.3% national screening rate for women 40 to 65 years old. However, closer review found 2% of the women had a diagnostic mammogram within that year, and another 24% of the women that had not been screened that year had been screened within 2 years of our inclusion dates, and another 5% had been screened in their lifetime. Conclusion. Though the study only had a 16% screening rate for the November 2018 to November 2019 year, 57% of the women under age 50 had participated in screening mammograms in their lifetime. This is much closer to the 65.3% national average. However, the national average did include women 40 to 65 instead of just 40 to 49, which I believe can negatively skew the data. Discussion and action plan. This study was done in hopes to benefit providers and patients by recommending an update to the United States Preventative Task Force 2009 recommendations and lowering the screening rate to age 40. This could possibly increase mammogram screening compliance rates, especially for the women in their 40s, and offer life-saving early detection. Mammogram screening rates for women aged 40 to 49 at a local clinic in Arkansas. Introduction and purpose. Breast cancer screening is an important primary prevention service. 1 in 8 women in the U.S. will be diagnosed with invasive breast cancer in their lifetime. Mammograms are the gold standard for screening because they can detect breast tissue changes before a mass is palpable, so less than 1 centimeter. Mammograms are also non-invasive and relatively inexpensive. However, guidelines for when a woman should initiate screenings are unclear. So the purpose of this study was to see if women falling in a gray area, age 40 to 49, were choosing to participate in screening mammograms at a local clinic in Arkansas at the rate of the national average. Guidelines. The United States Preventative Task Force recommends yearly screenings starting at 50, but women 40 and up can choose to participate in screening mammograms. The American College of Obstetricians and Gynecology recommends yearly screening beginning at 40, while the American Cancer Society says to start yearly screenings at 45 and then biennial screenings after 55. But women 40 and up may also choose to participate in screenings. Methods. The method for the study was a randomized retrospective chart review where a computer selected 100 charts for women ages 40 to 49. The charts were reviewed for screening mammograms from the dates of November 2018 to November 2019. Findings. The data showed only a 16% screening rate at the local clinic, which fell drastically short of the 65.3% national screening rate for women ages 40 to 65 years old. However, Closer review found 2% of the women had a diagnostic mammogram within that year, and another 24% of the women that had not been screened that year had been within the past 2 years of our inclusion dates, and an additional 5% had been screened in their lifetime. In conclusion, though the study only had a 16% screening rate for the November 2018 to November 2019 year, 57% of the women under 50 had participated in screening mammograms in their lifetime. This is much closer to the 65.3% national average. However, the national average did include women aged 40 to 65 instead of just 40 to 49, which could have negatively skewed the data for the study. Discussion and action plan. The study was done in hopes to benefit providers and participants by recommending an update to the U.S. Preventive Task Force 2009 recommendations and lowering the screening rate to age 40. This could possibly increase mammogram screening compliance rates, especially for women in their 40s, and offer life-saving early detection.
Hi everyone, my name is Taylor Long. I'm a Master's in Science Nursing Family Nurse Practitioner student at Arkansas State University. And for Create a State, I have done a project on aspirin use for primary prevention of cardiovascular disease. Here is my Create a State poster presentation, which will be discussed in detail in the next following slides. Introduction and purpose. Cardiovascular diseases, or CVD, are the #1 cause of death globally, with more than 17.9 million people dying from CVD in 2016. In Arkansas, heart disease is the leading cause of death, while cerebrovascular disease, or stroke, is the 4th leading cause of death. CVD includes a group of disorders affecting the heart and blood vessels, which include coronary heart disease, cerebrovascular disease, peripheral arterial disease, rheumatic heart disease, congenital heart disease, and deep vein thrombosis or pulmonary embolism. Primary risk factors for CVD include an advanced age, male gender, race or ethnicity, hyperlipidemia, hypertension, diabetes, and tobacco abuse. Many evidence-based studies have shown the addition of a low-dose daily aspirin can help to decrease the risk of CVD events by 17% in patients who are considered at an elevated risk. The United States Preventive Service Task Force recommends that adults aged 50 to 59 who have a 10-year risk for cardiovascular disease that is greater than 10% take a low-dose daily aspirin for primary prevention of CVD if they are not at an increased risk for bleeding, have a life expectancy of at least 10 years, and are willing to take aspirin daily for at least 10 years. Despite this recommendation, studies have shown that the national average of adults taking low-dose aspirin daily for primary prevention of CVD is only 30%. Here are some images on statistics involving cardiovascular diseases, as well as some risk factors. Objectives. The purpose of the study was to examine the percent of patients aged 50 to 59 at a rural Arkansas clinic taking a low dose or 81 milligram daily aspirin for primary prevention of cardiovascular disease in comparison to the national average of 30%. In determining this percentage of patients taking aspirin for primary prevention of CVD compared to the national average, providers will be able to see if their prescribing practices are at goal or if they need improvement compared with the rest of the nation. Methods. A retrospective chart review of 50 electronic medical records was completed at a rural family practice clinic in Arkansas. Information was collected and entered into the ASCVD Risk Estimator Plus to obtain a 10-year CVD risk. Information obtained included age, sex, race, blood pressure, last cholesterol level, history of diabetes, smoking status, and if the patient was on any antihypertensives. Mathematical calculations were then used to determine the percent of patients which had a greater than 10% 10-year CVD risk who had aspirin listed on their medication list. Population included males and females 50 to 59 years of age with a greater than 10% 10-year risk for CVD based on the ASCVD Risk Estimator Plus who have visited the clinic between January 1st and November 30th, 2019. Exclusions included those who had a known history of CVD, those who were younger than 50
or older than 59 and who had less than a 10% 10-year risk for CVD. Findings: the percentage of patients taking aspirin for primary prevention of CVD at a rural clinic in Arkansas was 26%. Discussion and action plan. Compared to the national average of 30%, the rural Arkansas clinic was 4% less in prescribing aspirin to patients with a greater than 10% 10-year risk for CVD. Limitations include an unknown risk for bleeding, as a higher bleeding risk is a contraindication for aspirin use, and the possibility of aspirin not being listed on their home medication list, as this can be purchased over the counter as well. Providers should be well educated on current recommendations to help reduce the risk of CVD, as it is the leading cause of death in the United States. However, aspirin is consistently underutilized. Most patients who are seen in the family practice setting have multiple risk factors that include obesity, diabetes, hypertension, and hyperlipidemia. More needs to be done to protect these patients. More than 70% of people with a 10-year CVD risk of greater than 10% were not on a daily low-dose aspirin as recommended by the United States Preventive Services Task Force and supported by the American Diabetes Association, American College of Chest Physicians, American Heart Association, and the American College of Cardiology. This shows that there's room for improvement for the rural family practice clinic in Arkansas, as well as the rest of the nation. Further education should be given to prescribers on the use of aspirin for primary prevention of CVD. Included is a reference list. I'd like to acknowledge Dr. Tammy Hawkins, clinical instructor, and Dr. Mark Foster, advisor.
Hello, my name is Caitlin Lumpkin. I'm a family nurse practitioner student at Arkansas State University in Jonesboro, Arkansas. The name of my study is Wait and See Approach for the Initial Treatment of Acute Respiratory Infections. Introduction. Antibiotic resistance is a problem all over the U.S. and also across the globe. According to the CDC, there are 47 million unnecessary antibiotic prescriptions written each year, and most of the unnecessary prescriptions are for acute respiratory infections that are most commonly caused by viruses or bacterial infections that do not always require an antibiotic. Most upper respiratory infections have an incubation period of 3 to 10 days. The CDC includes fever, cough, rhinorrhea, nasal congestion, postnasal drip, sore throat, headache, and myalgias as symptoms. Some patients may experience symptoms for up to 2 weeks, such as smokers. Acute respiratory infections are usually viral and self-limiting. More than 90% of acute bronchitis has no bacterial cause. A wait-and-see approach for the initial treatment of acute respiratory infections is one method that can help reduce the amount of antibiotics prescribed. With a wait-and-see approach, patients either do not receive any medications or they receive medications that help to treat their symptoms, such as a cough suppressant. The patients then follow up with their provider and only receive an antibiotic if their symptoms worsen or if an antibiotic is then indicated. In 2017, 70% of antibiotics were unnecessarily prescribed for acute upper respiratory infections for patients aged 20 to 64. The purpose of this research study is to raise awareness of antibiotic resistance. Methods. An IRB was obtained through Arkansas State University. A retrospective chart review was used to compare the percentage of antibiotics prescribed for initial treatment of acute upper respiratory infections in adult patients with no comorbidities at a local family practice clinic in Northeast Arkansas to the national average of 70%. Charts were selected by using the ICD-10 code J06.9 or acute upper respiratory infection. Examination dates were from January 2019 to November 2019. 15 charts were reviewed. Information obtained from charts include age, gender, race, smoking status, if an antibiotic was used as the first-line treatment, and if so, which antibiotic was used, and if a wait-and-see approach was implemented before prescribing the antibiotic. Population. Charts of patients between the age of 18 and 40 were included. Exclusion criteria, charts of patients with comorbidities such as COPD, congestive heart failure, charts of pregnant patients, and charts of patients younger than 18 or older than 40. Findings. The percentage of patients that a wait-and-see approach was utilized as the initial treatment was 73%. 40% of patients were given an antibiotic as treatment. One patient was also diagnosed with a UTI, and another patient was also diagnosed with pharyngitis. So the antibiotic that was chosen was used to treat both those conditions and the upper respiratory infection. 2 patients were given Zithromax, 2 patients were given doxycycline, 1 patient was given amoxicillin, and 1 patient was given Levaquin. There were 4 patients that received an antibiotic first before a wait-and-see approach was initiated. 27% of the patients were smokers. This chart compares the choice of treatment. 73% used a wait-and-see approach as the first-line treatment, and 27% were prescribed an antibiotic as the first-line treatment. This chart shows the percentage of unnecessary antibiotics prescribed. The Family Practice Clinic in Northeast Arkansas had 26% compared to the national average of 70%. Discussion and action plan. The local family health clinic in Northeast Arkansas is below the national average of prescribing unnecessary antibiotics. Even though it was below the national average, education should be provided regarding the antibiotics that were prescribed too soon. The wait-and-see approach was utilized for 73% of the patients, so it is unknown what was different about the patients that were given an antibiotic. Antibiotic resistance continues to occur and is up to providers to do their part by not prescribing unnecessary antibiotics. Further research needs to be performed due to limitations. There were several limitations of this study. To start off, there was only 32 charts that utilized the ICD-10 code of J06.9. Only 15 of those were able to be used because of the exclusion criteria. The clinic is a small rural clinic, so there's limited geographical sampling, and then patients over the age of 40 were not included due to a higher risk of having comorbidities such as COPD. I would like to acknowledge my clinical instructor and advisor, Lauren Hancock. References are available upon request. Thank you.
Hi, my name is Holly McGuire, and I'm in the Masters of Nursing Family Nurse Practitioner program at Arkansas State. My project examines a local clinic's cervical cancer screening rate in female patients. Since cervical cancer is the first most common cancer in women, I thought it'd serve good purpose to research this topic more to see if a rural community aligned with current screening guidelines compared with the national average rate of 80%. The United States Preventive Services Task Force have updated their guidelines over the years. They no longer recommend screening anyone under the age of 21 years old, which has been a change that I've noticed since my first Pap test was recommended to be performed when I was 18 years old. Current guidelines are as follows. No screening for women under the age of 21 years old. Women aged 21 to 29 years, cervical cytology alone every 3 years. Women aged 30 to 65 years, cervical cytology alone every 3 years, or high-risk HPV testing alone every 5 years. No women greater than 65 get screened who have had adequate prior screening. Women who have had a hysterectomy with removal of the cervix and no history of cervical cancer receive screenings either. I performed a retrospective chart review on February 24, 2020. A total of 3 patients' charts met the inclusion criteria and were included in this study. The clinic was at 100% when reviewing the charts to establish whether the clinic was following the most recent guidelines from the United States Preventive Services Task Force. Limitations to this study include a small sampling size of only 3 patients' charts. It was found after the fact that the clinic refers most gynecological patients to a specialist OBGYN. This being so, it is recommended that female patients still get educated in the clinic about appropriate screening times and recommending the HPV vaccine to help guard against cervical cancer. Cervical cancer used to be the leading cause of cancer deaths for women in the United States. However, in the past 40 years, the number of cases of cervical cancer and the number of deaths from cervical cancer has decreased significantly due to women getting regular Pap tests. Thank you.
Hey there, this is Tia Mitchell. I'm a family nurse practitioner student here at Arkansas State, and this is my project, Colorectal Cancer Screening Rates at a Local Clinic. Hope you enjoy. At this time, I'd like to say thank you to my project advisor, Dr. Christopher Jordan, as well as my clinical instructor, Miss Lauren Hancock. Here's a snapshot of my poster in its entirety. You'll have to excuse some of the wording got jumbled from whenever it was uploaded onto this program and I couldn't figure out how to fix it. For that purpose, I have broken down each section of the poster and we'll discuss it shortly. I chose this topic because colorectal cancer is so prevalent. It's the 3rd most diagnosed cancer in the world and the 4th leading cause of cancer-related deaths globally, and that number is only expected to increase. Our population's getting older. Advanced age was the most significant risk factor, 68 years being the median age at diagnosis. The national average of colorectal cancer screening was 67.7%, and that paid no attention to what type of testing was used. Missouri was 65.5%, so right behind there. Missouri's where I'm from. Shockingly, only 58% of the people in the United States have had a colonoscopy. The recommendation I used was from the United States Preventative Task Force, which recommended screening begin at age 50 years and continued until age 75 years. How often screening should take place depended on the type of test performed and the amount of risk that the person had of getting colorectal cancer. The purpose of this study is to compare the colonoscopy screening rates of patients 50 to 75 years old in a local family practice clinic in Bernie, Missouri, to the national average of 58% of patients who are also 50 to 75 years old who are up to date on colonoscopy screening. Inclusion criteria for the study were patients who were 50 to 75 years of age, had the ICD-10 code for screening for malignant neoplasm of the colon. They had a colonoscopy report in their chart within the last 10 years. We had a goal of 50 patients charts that met inclusion criteria with visits between August 1st and November 18th in 2019. However, only 20 patient charts met the inclusion criteria and data was analyzed using Excel. I'm a visual learner, so here's just a breakdown of the different screening methods that were used. Obviously, 10 out of the 20 charts had nothing recorded, but other screening methods were colonoscopy, Cologuard, fecal occult blood test, and fecal immunochemical testing. So this is just a visual of the different screening averages at the national, state, and local level. As you can see, 50% of the charts reviewed had some type of screening method documented, but only 25% of the total charts reviewed had a colonoscopy documented. As you can see, that is way below Missouri's average of 65.5%, as well as the national average of 58%. So I found that 50% of the 20 total charts reviewed were up to date on various colon cancer screening methods, but only 25% of charts were up to date on colonoscopies within the last 10 years. And here's just another visual. As you can see, the 50% with the various testing methods compared to 25% who are up to date with colonoscopies. Limitations included the small sample size and that only one clinic was observed in Southeast Missouri. The research suggests that the clinic does not fully utilize the recommended screening tools for colorectal cancer. Proper use of these screening tools can increase awareness in patients who may be at risk for developing this type of cancer. Prevention is key, so it is very important that the clinic begins to utilize these screening tools so that those patients at risk for cancer have a plan of care in place. And also, since 50% of the patients did not follow through with screening, additional studies may be completed to further evaluate possible reasons they are not complying with the guidelines. And here are my references. Additional references are available upon request. Thank you. Bye.
This is an analysis of the osteoporosis screening rate in a local family practice clinic. My name is Wanda Mooney, and I'm a graduate student at ASU, and I would like to also acknowledge Dr. Savannah Coyne, who's my clinical instructor, and Dr. Christopher Jordan, who is my professor as well as my mentor. Osteoporosis is a debilitating bone disease which is characterized by low bone mass and has the potential to cause bone fractures that can negatively impact the elderly's morbidity and mortality. The focus of this study is geared toward postmenopausal women, as they are considered to be the group that is most at risk. It is beneficial to determine the bone density screening rates locally to ascertain how closely these rates compare to the national average. The purpose in screening for osteoporosis is to identify those patients who have low bone mass and provide appropriate treatment prior to them suffering from a fracture. Additionally, the United States Preventive Task Force recommends bone density testing beginning at age 65 for this patient population. This slide is an example of what the normal bone density would look like, comparing that to one that has been affected by osteoporosis. The objective of this study was to compare the number of female patients aged 65 to 85 who have had a bone density screening prior to a fracture versus those who have not. The data for this project was collected utilizing a retrospective chart review, and all charts were randomly selected. 50 charts were selected by searching for the ICD code, which represents the encounter for screening for osteoporosis. The data was only used from patients that were seen in the clinic within a year time frame from November 1st, 2018 to November 1st, 2019. Of course, all male patients were excluded from this research project, and any female patient who was younger than 65 or older than 85. Of the 50 female patients aged 65 to 85, 32 had an indication within their medical record for osteoporosis screening, and 18 did not. This calculates to 64%. When comparing that rate to the national average of 76%, this gives a 12% variance. It's well understood that decreased bone density can lead to fractures. Studies have shown that 1 in 2 women will break a bone in their lifetime due to osteoporosis. For women, the incidence is greater than that of a heart attack, a stroke, and breast cancer combined. This screening should be encouraged, and it is covered by Medicare initially and every 2 years following any necessary treatment that might be prescribed. The results from this study will allow clinic administration to identify an opportunity for improvement regarding inadequate practices in an effort to positively impact the health of this vulnerable patient population.
Hello, everybody. My name is Angela Myers Obermeyer, and I am a nurse practitioner student at Arkansas State University. Before I do my presentation, I would like to thank Dr. Jordan, Tammy Bell, and Lauren Hancock for all their assistance and guidance over the last year and a half with my project. My research project is a retrospective chart review on fall assessment in a local primary care facility. I wanted to compare the fall risk assessment in a local primary care facility with the MIPS benchmark. Now, falls are oftentimes overlooked by primary care providers due to other things such as diabetes, hypertension, heart failure. So many times fall risk is not really at the top of a primary care provider's mind. However, according to the Center for Disease Control and Prevention, 1 in 4 Americans aged 65 and older fall each year. Falls are the leading cause of injury and the most common cause of non-fatal hospitalization admissions in the elderly population. Falls also result in 2.8 million injuries treated in the ER department and includes 800,000 hospitalizations with more than 27,000 deaths. So you can see that falls, especially in the elderly population, are very concerning. In 2015, the total cost of fall injuries was $50 billion. And oftentimes, Medicaid and Medicare are shouldering 75% of these costs. This cost is expected to rise to reach an estimated $67.7 billion by the year 2020. In addition to hospitalizations and injuries, the rate of deaths from falls in persons 65 and older has increased by 31% from 2007 through 2016. The fastest growing rate among these individuals was in people 85 years and older. One of the best ways to assist patients over 65 is for the provider to assess their fall risk annually. The American Geriatric Society guidelines on fall risk screening and assessment recommend annual screening for all individuals over 65. So I did a retrospective chart review where I looked at 50 charts at a local primary care facility. I looked at the charts from dates January 1st of 2019 through November 18th of 2019. This was a random selection of 50 individuals. I assessed their charts to see if those individuals, when at their primary care appointment, had been given a fall risk assessment. Of the 50 individuals, only 39 out of 50 had received a fall risk assessment. This is 78%. This is obviously well below the MIPS benchmark of 98.5%. The inclusion criteria in my study was any individual 65 and older. The exclusion criteria was individuals under 65. When I discussed my findings with the local clinic, they were shocked at how low they were performing. They really thought they were doing a good job of assessing falls. It is imperative that we as providers ensure that our patients are safe. Especially in the individuals 65 and older, I think primary care physicians need to be educated on fall risk assessment and also further education with the patient on how they can lower their risk for falls. So this is only going to become a more growing problem as the United States population gets older and older. So it is important at this time that we find a way to make sure all providers are assessing their elderly patients on a yearly basis, if not more often. Thank you for listening.
Hello everyone. I want to start this presentation by introducing myself. My name is Morgan Noble and I am in the 2020 Family Nurse Practitioner graduating class at Arkansas State University. The title of my research presentation is Pediatric Obesity Screening Rates. This presentation is a culmination of the work I have done over the last year and a half of this graduate program. I would like to take this opportunity to introduce my faculty mentors that have played a significant role in this research. They are Dr. Chris Jordan, who is my advisor, and Ms. Tanya Mead, who is my clinical instructor. This is the poster that would have been displayed at Create at State. This poster displays the introduction to the research, the purpose and objectives of the research, the methods of the research, the population that was included in the research, the findings of the research, the discussion, and the action plan. It also displays the acknowledgments and references. I know this is difficult to view in this format, so I have broken the poster down into different slides to make it a little bit easier to see. I think we would all agree that obesity is a problem in our country that affects all populations, and the pediatric population is no different. This puts these children and adolescents at risk for poor health. The prevalence of obesity is 18.5%, and that translates to about 13.7 million children and adolescents ages 2 through 19. Obese children and adolescents have an increased risk of developing type 2 diabetes, asthma, fatty liver disease, cardiovascular disease, and they may also experience more mental health and psychological issues like depression and low self-esteem. In order to combat these statistics, the United States Preventive Services Task Force recommends that clinicians screen for obesity in children and adolescents 6 years and older and offer or refer them to comprehensive intensive behavioral interventions to promote improvements in weight status. The purpose of this study is to analyze what percentage of children and adolescents ages 6 through 18 are being screened for obesity in a local clinic in Manila, Arkansas. And then if they are overweight or obese, are they being offered comprehensive, intensive behavioral interventions to promote improvements in their weight status? This is a chart that I found on the CDC website that I found interesting. It kind of goes along with the statistics that I found, and it just shows the prevalence of obesity among youth ages 2 through 19. And this chart goes on and breaks it down by sex and age. And if you will look, you can see that once kids reach 6 years old, from that point as they age, the prevalence of obesity increases. The objective of this study is to analyze the pediatric obesity screening rate of a rural Arkansas clinic with the national screening rates in consideration of the recommendations by the United States Preventive Services Task Force for all children ages 6 through 18. In determining whether the pediatric obesity screening practices at this clinic are better or worse than the national average, providers will be able to gain insight into their current screening practices and provide a reference point that they can utilize to set future goals. Now we're going to talk about the methods I used to obtain this research. First, IRB was obtained through Arkansas State University. The study was conducted using a retrospective chart review, and then 50 charts were reviewed through an EMR in a rural primary care clinic in Mississippi County, Arkansas. A data collection tool was used to gather and record data, and the data collected included age, gender, BMI, whether or not a screening was performed, and if interventions were offered. The population included both male and female patients ages 6 through 18 who visited the clinic between the dates of January 1st, 2017 and November 15th, 2019. Exclusion criteria included patients who were younger than 6 or older than 18. This study found that the rate of obesity screening in a rural clinic in Mississippi County for children ages 6 through 18 is 100%. 34% of the 50 patients that I reviewed were found to be in the obese category. My intention was to compare that percentage to the national screening average, but I was unable to obtain that through my research. Therefore, a comparison could not be made. When we consider the recommendations made by the United States Preventive Services Task Force for these individuals, screening practices of the practitioners at this rural clinic that I was at were found to be satisfactory. However, there is still room for improvement. The study concluded that this clinic screened 100% of their patients. Of the 50 charts that I reviewed, 17 of them were found to be in the obese category. Only 35% of that 17 that were found to be obese were offered comprehensive behavioral intervention. So this leaves significant room for improvement in that aspect of the recommendations. The acknowledgments we've already mentioned, and then the references are here on the bottom right.
Hello, my name is Hadley Owens. I'm a Master's of Science nursing student at Arkansas State University. The title of my project is Colorectal Screening Education and Patient Compliance. Colorectal cancer will afflict more than 101,420 people this year, with 44,180 cases of rectal cancer alone. In 2018, in the United States alone, colorectal cancer was the third leading cause of cancer-related deaths, which total more than 606,000 per year. Arkansas is predicted to incur over 6,730 deaths in 2020, with an estimated total of newly diagnosed colorectal cancer patients of 16,580. According to the World Cancer Research Fund, colorectal cancer is the third most commonly occurring cancer in men and the second most affecting women, with lung cancer as the primary killer for men and breast cancer as the leading cause of death in women. The purpose of this study is to identify any barriers to having indicated populations tested for colorectal cancer. For this study, the main barrier that is to be identified is whether the patient received any education from the provider regarding having a colorectal screening performed. This is a descriptive study. It was conducted at a local family clinic in Arkansas through a retrospective chart review. 61 electronic charts were randomly selected between January 1st, 2019 and February 1st, 2020. Population of the patients aged between 50 to 65 years old with a CPT code marked in their chart that indicated either a fecal biomarker or colonoscopy test had been ordered. Inclusion criteria with both male and female patients, ages between 50 to 65. Charts indicating colorectal screening CPT codes of 81528 for Cologuard, which is a fecal biomarker, and 45378, which is a colonoscopy. Exclusionary criteria were male and female patients less than 50 years old and greater than 65, and patients who had had previous colonic studies performed. Analysis of the 61 patient charts indicated that only 84% of the sample population had their screenings performed. 57% of those had zero education documented in their charts. And of the 16% of patients that did not have their screenings performed, 0 of those patients received any kind of education. For our discussion and action plan, the results indicate that there is some correlation between patient education and completion of colorectal screenings. This will help us establish a standard for patient education and documentation thereof. This research can be continuated, which indicates for future practice improvement. Increasing the number of colorectal screenings indicates a reduced mortality rate as a result of colorectal cancer being discovered. Utilization of fecal biomarkers presents a lower cost alternative that also provides greater privacy for some patients. Limitations for this is it was a small sample size. Data was collected from one particular clinic in Northeast Arkansas. No standard for grading patient education within the provider to patient interaction. And it's a retrospective chart review, so it doesn't allow any interviewing of patients to determine the actual cause of attrition for the patients electing not to have their colorectal screenings performed. I would like to acknowledge Dr. Christopher Jordan and Ms. Lauren Hancock for their assistance with this project.
Hello, my name is Robin Phillips. I'm an MSN FNP student at Arkansas State University. Today, I will be presenting my Create a State presentation on research that I did on how many people ages 25 to 35 are being routinely screened for HIV. I would like to thank my mentors, Dr. Mark Foster, Dr. Christopher Jordan, Otasha Hadley, and Lauren Hancock for their help during this process. I chose this topic for research because 1.1 million Americans are living with HIV or AIDS. 15% of those are unaware, which is 1 in 7 people. That means 1 in 7 people with HIV do not know they are infected. The U.S. Preventative Task Force recommends that all patients ages 15 to 65 be screened for HIV. For the purpose of this study, I narrowed the age down to a 10-year difference for ages 25 to 35. When I began this research, I was only going to review charts for patients being seen for STI or STD testing, but however, all patients seen for STI, STD testing in the clinic I did the study were always tested for HIV as well. Therefore, I only reviewed charts of patients being seen for a wellness exam. The clinic I used for this quantitative retrospective study uses an electronic charting system which prompts the provider to ask the patient receiving their exam if they would like HIV testing as part of their visit. Of the 50 charts reviewed, 34 requested HIV testing and 16 declined. Of the 34 tested, 2 patients received a positive test result. That's 6% of the population tested. With these findings and other supportive literature, I hope more healthcare providers become aware of the number of people silently living with HIV or AIDS. By adhering to the U.S. Preventative Services Task Force recommendations, more people can become aware of their HIV status and hopefully decrease the transmission of this disease.
Hello, Create a State. My name is Jarrett Powell. I'm a senior family nurse practitioner student here at Arkansas State University. I've completed all of my formal education here in Northeast Arkansas, so the health and wellness of the individuals of this community are near and dear to my heart. The purpose of this research was to evaluate how well primary care clinics in the region are vaccinating patients 19 to 64 years old who have been diagnosed with a chronic condition as identified by the CDC as being high risk for pneumonia. One may ask, is the pneumonia vaccine really that important? Well, for an individual who suffers from chronic illness, the answer is yes. The pneumococcal vaccine will decrease a patient's risk of getting pneumonia in the first place, but also the economical burden to the patient and healthcare system will be drastically reduced. In 2004, there were 119,000 hospitalizations and almost 2 million outpatient visits for pneumococcal-related infections. Pneumonia infections in adults aged 19 to 64 accounted for approximately $4 billion in direct medical costs. As primary care providers, we should encourage the use of vaccinations to not only increase the well-being of our patients, but also to save billions of US dollars. The objective of this study was to determine if a local primary care clinic was vaccinating patients aged 19 to 64 with a chronic condition appropriately compared with the National Health Interview Survey's statistics. These statistics would then be compared to the Healthy People's 2020 goal for vaccination rates of individuals aged 19 to 64 with chronic conditions. The population of this study was adults aged 19 to 64 who have a chronic condition. The CDC identifies patients who smoke, have heart disease, lung disease, liver disease, diabetes, and alcoholism at risk. They also identify immunocompromised patients such as HIV, chronic renal failure, and nephrotic syndrome. The third section the CDC identifies is patients who have CSF leaks or cochlear implants. This group was not evaluated in this study. Healthy People 2020 identified a goal to have 60% of patients 19 to 64 who have a chronic condition to be vaccinated. The International Health Survey identified that 20.3% of primary care offices vaccinate these patients appropriately. The clinic where I conducted research vaccinated 23 out of 50 patients reviewed. That is 46%, which is much better than the International Health Survey of 20.3, but does not meet the goal of Healthy People 2020. Of the population, 48% of patients diagnosed with diabetes were vaccinated. 100% of patients with chronic liver disease were vaccinated. 40% of patients with chronic kidney disease were vaccinated. 50% of people who were identified as smokers were vaccinated. 50% of patients with chronic heart disease were vaccinated appropriately. 57% of patients with COPD were vaccinated. 33% of patients with asthma were vaccinated, and 50% of patients who have a malignancy were vaccinated. This is simply a helpful graph to demonstrate the finding of the primary care office I did research at. Compared to the national average of 20.3% of patients vaccinated who are high risk for pneumonia age 19 to 64, the local clinic here in Northeast Arkansas did it very well at 46%. Unfortunately, the clinic did not meet the Healthy People 2020 goal of 60%. The action plan of this study would be to present this data to the clinic so they could improve their vaccination rates and to achieve the 20% Healthy People 2020 goal.
Hey guys, my name is Haley Prince. My presentation is titled, Are Healthcare Providers in a Local Family Practice Clinic Counseling Patients age 18 to 60 with a BMI greater than 30 on lifestyle modifications for weight loss compared to the national average. I also want to acknowledge my faculty mentor, Dr. Christopher Jordan. Thank you so much for your help. This is my poster presentation. I will provide a detailed outline of this presentation and study. I hope everyone enjoys it. I'd like to begin my presentation with discussing what obesity is. It is defined as excess adipose tissue that is quantified via calculation of a patient's body mass index or BMI. This is done by dividing the patient's weight in kilograms by the patient's height in meters squared. Obesity is considered when the patient's BMI is 30 or greater. Obesity is an immense health concern worldwide and underlies many of the leading causes of preventable deaths. Some preventable diseases that occur with obesity include hypertension, hyperlipidemia, diabetes mellitus, cardiovascular disease, strokes, musculoskeletal disorders, depression, various disabilities, and of course, death. A healthcare provider must address the diagnosis of obesity and provide proper counseling and education on ways to overcome it or prevent the development of the comorbidities or death. The purpose of this study is to determine if healthcare providers are recognizing that a patient is obese based on their BMI, counseling them on lifestyle modifications to lose weight and prevent the development of chronic diseases, and documenting that it was discussed during the visit. This non-research retrospective chart review will provide information and insight to acknowledging that a patient is obese and counseling them on lifestyle modifications for weight loss management in the primary care setting. Awareness that there is a lack of provider compliance with this method will also be revealed. This project was conducted in a local primary care setting in a rural clinic in the northeast region of Arkansas. Data was collected using a randomized sample through a retrospective chart review. 50 charts were randomly selected between the dates of January 2019 to November 2019. The charts included patients seen in the clinic for problem visits or routine checkups. The sample included male and female patients aged 18 to 60 with a diagnosis of obesity or morbid obesity or a BMI of 30 or greater. Data was analyzed using Microsoft Excel software to define the statistical significance. Limitations to this study include that it was a small sample size of only 50 charts, there was one provider at the primary care clinic location, and data collection was from one rural clinic. Inclusion criteria include age 18 to 60, BMI of 30 or greater, an ICD-10 code of E66.9 or E66.01, active patients seen in the clinic between January 1, 2019 and November 18, 2019, and documentation of counseling of lifestyle modifications for weight loss management. Exclusion criteria are the complete opposite of the inclusion criteria. I'd like to take a moment to discuss this photo. It is most definitely an eye-opener or a revelation. These MRI scans may well be the two most powerful motivations for heart patients to step away from unhealthy tendencies. They are from a National Geographic feature all about body fat. The woman on the left is 5'6", 250 pounds, and has a BMI of 40.3, which makes her morbidly obese. The woman on the right is 5'5", 120 pounds, with a BMI of 20, which is considered healthy. Please note how the ankles of the woman on the left are now tortuously deformed due to the equivalent weight of one extra person she's been carrying around. I also want to note that the internal organs have so much excess adipose tissue surrounding them compared to the healthy person. This shows individuals that eating unhealthy diets and avoiding exercise not only affects the way that you look and feel on the outside, but it also debilitates you on the inside. The results of this study revealed that in this current clinic setting, 24% of the patient population who were diagnosed with obesity received counseling for weight reduction. This equates to 12 out of 50 charts. Although this percentage is greater than the national average of 18%, providers must work harder to increase this percentage. Weight loss management and prevention of obesity prevents the development of several different diseases or illnesses as mentioned. Recognizing obesity as a disease could lead to reimbursement for obesity interventions and may help providers focus their attention on strategies to manage the obesity epidemic. By losing weight or preventing obesity, individuals are preventing possible deaths and avoiding unnecessary healthcare-related costs. Because of this, it is crucial that providers are diagnosing obese patients correctly and providing proper counseling for prevention and management. In the setting where the project was conducted, it was noticed that for each patient's visit, the template only included an area at the very bottom of each chart to include education provided in a yes-no format. When counseling or discussion did take place, it was only documented under the Education Provided tab at the very bottom of the chart, which did not include details of the discussion that took place or specify what education was provided. It would be very useful to providers to add an area to the template labeled specifically for weight loss management, which would increase the occurrence of initiation of counseling and documentation of discussions. In addition to adding this template, there should be more options in the educational portion of the visit, other than yes/no to education for obesity. It should include what education was provided, if there were decisions made regarding diet or exercise, or if the patient refused education or counseling altogether. By making these changes, nurse practitioners can increase the occurrence of providing the needed education to obese patients. The provider should discuss with the patient the importance of goal planning, fitness tracking, and regularly scheduled check-in times for patient progress and motivation. It is imperative to counsel these patients every visit to prevent the increased development of comorbidities and to assist in the reduction of healthcare-related costs. It is our responsibility as primary care providers to provide proper education to our patients to inevitably save lives. Once again, I want to thank my faculty mentor, Dr. Christopher Jordan, for all of your help, and I hope everyone enjoyed my presentation. Thank you so much.
Hello, I am Carly Sexton. I recently conducted a chart review over colorectal cancer screening rates. I want to first acknowledge my mentor and advisor, Dr. Chris Jordan, and my clinical instructor, Tanya Mead, who both helped guide me along this path. I was inspired to review colorectal cancer screening rates due to a young man, 44 years old, who was recently diagnosed with stage 4 colorectal cancer in the hopes to raise awareness of symptoms, screening recommendations, and really to just get the conversation going with their primary care providers. So let's get started. Colorectal cancer is responsible for being the second leading cause of death related to cancer and the third most common cancer of men and women. In 2016, over 141,000 patients were diagnosed with colorectal cancer. Studies have shown that colorectal screening reduces colorectal cancer rates. More than 90% of the cases occur in people who are 50 years or older. Modifiable lifestyle risk factors that may contribute to the increased risk include lack of exercise, a diet low in fruits and vegetables, low fiber and a high fat diet, overweight and obese, alcohol consumption, and tobacco abuse. The purpose of this study, again, is to raise awareness of the low screening rates in the United States. The primary objective of this study is to compare the screening rate at a rural Arkansas clinic with the national screening rate in consideration of the recommendation by the USPSTF to screen patients aged 50 to 75 for colorectal cancer. The study will use a retrospective chart review to gather information pertinent to the topic of interest, allowing all providers at the clinic insight into whether their current method of screening practices are up to par with the national average. "50 charts were reviewed through the EMR in a rural primary care clinic in Mississippi County, Arkansas. Data collected included age, sex, race, if the patient was screened, yes or no, and if they were, which method was used. IRB was obtained through Arkansas State University. Inclusion data for the chart review included both male and female patients aged between 50 to 75 that visited the clinic between the dates of January 2017 and November 2019. Patients that were excluded from the study were younger than 50 or older than 75, and patients with a total colectomy. Out of the 50 patients charts reviewed, data resulted in 56% of patients were screened and up to date with colorectal screening, 44% of patients were not screened, 11% of the patients not screened refused their screenings. In the 56% of patients screened for colorectal cancer, 89% underwent the gold standard colonoscopy, while 11% used other modalities such as FIT and Cologuard. The average age of patients reviewed in the study was 61 years old. When considering recommendations by the USPSTF to screen patients aged 50 to 75 for colorectal cancer, the screening rate at the rural Arkansas clinic involved in the study was found to be lower than the national screening rate for colorectal cancer at 67.3%. Based on evidence of available research, there is high indication that colorectal screening reduces the risk of colorectal cancer. However, awareness and education seems to be lacking nationally. More than 40% of the qualifying patients in this study were not screened for colorectal cancer recommended by the USPSTF, indicating a decrease in the rate of colorectal cancer when screened properly and leaving a significant room for improvement. This study concluded that a rural Arkansas clinic in NEA had a significantly lower screening rate of 56% compared to the national average of 67.3% when considering the USPSTF colorectal screening recommendation. Further education and awareness is needed for patients and providers regarding screening rates locally and nationally. Healthcare providers should be advocates on colorectal screening and provide specific recommendations individualized to patients on which screening modality would best suit that patient. I also want to add that I am aware of the new 2020 USPSTF colorectal screening recommendation that has dropped the age to begin routine screenings to age 45. However, I have seen that many insurances will not cover the expense for routine screenings if not showing any abnormal symptoms leading to colorectal cancer. Again, I am here to advocate for my patients by raising awareness and beginning the conversation of colorectal screenings in the hopes all routine health prevention tools become more financially expendable. I want to thank you for a moment of your time. Attached is a reference list, and additional references can be provided upon request. Again, I want to thank Dr. Jordan and Tanya Mead for all their guidance in this process.
Hello, my name is T.C. Shelton, and I'm a graduate student earning a degree as a family nurse practitioner. This quality improvement project investigated a small clinic in Grant County, Arkansas for tobacco use screening and cessation interventions. According to the CDC, tobacco use is the leading cause of preventable disease and premature death in the United States. In Arkansas, nearly 23% of all adults are smokers, with 54% being between the ages of 25 and 64. In Grant County, 18% of adults identify as tobacco users. Healthy People 2020 objectives for tobacco use seek to increase tobacco screening and tobacco cessation interventions in the primary care setting. The purpose of this project was to investigate the clinic's effectiveness in providing tobacco screening and tobacco cessation interventions. The potential revenue gained and lost from cessation counseling was also evaluated. The objectives for the project was 1, to identify tobacco users from non-tobacco users using HCPCS and ICD-10 coding. 2, identify any counseling interventions that were provided using CPT codes. 3, any pharmacological interventions, specifically any prescriptions for varenicline, also known as Chantix, that was prescribed. And last, investigate the amount of lost revenue by not providing cessation counseling. To gather data, a modified algorithm derived from the Merit-Based Incentive Payment Program for tobacco screening was used. Using the clinic's electronic medical record, identification of patients age 18 and older with at least 2 patient encounters or at least 1 preventative encounter was performed to establish the eligible population. This would be the denominator in the equation. The percentage of patients age 18 years and older who were screened for tobacco use was determined from EMR records. Next, the percentage of patients age 18 and older who were screened identified as tobacco users or non-users was gathered using ICD-10 codes and HCPCS codes. The percentage of patients who were screened identified as tobacco users and received tobacco cessation interventions was calculated from CPT codes 99406 and 99407 and a search for varenicline, also known as Chantix. Data completeness for both screening and cessation interventions was performed using the equation provided in the Merit-Based Incentive Program Quality Measure Packet. For screening, the numerator included patients who were screened and categorized as tobacco users or non-users, patients who were not screened, and any documentation for not screening for tobacco use. The performance rate was determined by dividing the total number of patients recognized as users and non-users by the data completeness numerator minus any documented reasons for not screening. The results show that the clinic was very efficient in screening their patients for tobacco use. The clinic screened 100% of their patients. However, only 52% of the patients had any diagnosis code placed in their chart, that being either identification as a tobacco user or non-user. The clinic only counseled 34% of their tobacco-using patients. The clinic was found to be above the baseline and target goals as set forth by Healthy People 2020. As for revenue, only the fee schedules for Medicare and Medicaid were available for use. Values were calculated assuming that all patients either had Medicare or Medicaid. Counseling was provided 1,490 times, which generated a potential profit between $21,000 and $30,000. Taking into account the number of patients seen and subtracting the patients who had received counseling, lost revenue for both Medicaid and Medicare was determined. The result of this would be a potential loss from $11,000 to $30,000 to $37,000. In conclusion, the clinic performed above the national benchmarks, even screening 100% of their patients. The clinic could improve their performance by giving the patient a diagnosis code for their tobacco use or non-use. The clinic can increase their revenue by simply providing cessation counseling, even for a minimum of 3 minutes. Providers can aid the patient in quitting and improving their lifestyle by offering cessation medication.
Good evening. My name is Caitlin Simmons. I'm a senior in the Family Nurse Practitioner Program. My project for the Create a State Symposium is titled Tobacco Use Counseling Rates in Adult Tobacco Users within a Local Arkansas Primary Care Clinic. Tobacco use, including smoking cigarettes or cigars or smokeless tobacco, remains the leading cause of preventable death and disability in the United States. 31.4% of Arkansans reported using tobacco products in 2016, with 5,800 Arkansans dying from tobacco-related illnesses that year. The United States Preventive Services Task Force created a guideline in 2014 regarding tobacco use in adults. It's titled Counseling and Interventions to Prevent Tobacco Use and Tobacco-Caused Disease in Adults and Pregnant Women. This guideline recommends for providers to first ask about tobacco use, then provide tobacco cessation counseling and interventions for those who do use tobacco products. The national survey that inspired the task force to create this guideline was conducted from 2005 to 2010. The survey found that adults were screened for tobacco use 65.5% of the time in the primary care clinic setting and received tobacco use cessation counseling only 20.7% of the time if they said that they used tobacco products. Therefore, the purpose of my study was to compare the local Arkansas primary care clinic compared to this national average of 20.7%. I wanted to see where a primary care clinic in Arkansas stood compared to the national average. I first conducted a retrospective chart review, viewing charts from January 1st to November 19th, 2019 in a local clinic. I searched for the ICD-10 code Z72, which is screening for tobacco use, and found that 100% of the patients within this time period were screened for tobacco use. I then performed a second random retrospective chart review to find the first 100 patients that answered yes that they currently used tobacco products during that time. I then cross-searched for the ICD-10 code Z71.6, which is tobacco use cessation counseling. Of the 100 random charts, I was absolutely shocked to find that 100% of the patients had received tobacco use counseling. As a reminder, the national survey conducted resulted that only 20.7% of tobacco users received this tobacco use cessation counseling within the entire United States. But 100% of the tobacco users at this local Arkansas primary care clinic received tobacco counseling. The result of my study showed that the providers at this particular clinic understood the importance of following the guidelines recommended by the United States Preventive Service Task Force. By abiding by these guidelines, patients are at a greater chance of tobacco cessation and increasing their overall quality of life, as well as increasing the health of others by reducing secondhand smoke. The providers at this clinic are striving to increase the overall health of their patients. An action plan recommendation would be for these providers to share their strategies for screening and counseling patients for tobacco use cessation with other clinics within the area. This would help our overall number of tobacco users in this state, which is 31.4%, to hopefully lower and to help lower it within our community even further of Northeast Arkansas. I would like to acknowledge Dr. Chris Jordan and Dr. Mark Foster for helping me with this project. You can see my references were listed below, and please contact me if you have any questions. Thank you.
This is Lacey Songer. I'm a registered nurse and an FNP student in the master's program here at ASU. I'm going to be doing a poster presentation on peripheral arterial disease screening. Peripheral arterial disease, or PAD, is often asymptomatic and therefore it is an underdiagnosed disease. According to the CDC, approximately 8.5 million people in the U.S. have PAD. 12 to 20% of those individuals are older than the age of 60. It is expected by the year 2040, atherosclerosis will have a huge financial impact on medicine. Therefore, prevention, early detection, and treatment are crucial. There is an increased risk of death, cardiovascular disease, functional limitation, as well as limb loss associated with PAD. After coronary artery disease and stroke, PAD is the third leading cause of atherosclerotic cardiovascular morbidity. The American College of Cardiology and the American Heart Association have recommendations for PAD screening. They recommend to screen with ankle brachial index, ABIs, in patients at increased risk. This includes adults greater than or equal to the age of 65, adults greater than or equal to 50 years of age with a history of smoking or diabetes, and adults of any age with exertional leg symptoms or non-healing wounds. The objective of this study is to compare the percentage of patients 65 years of age or older that have been screened for PAD in a rural Arkansas clinic to the national average of primary care providers who use ABIs in their practice. This picture shows on the left a normal artery with no plaque buildup with good blood flow. On the right is an artery with plaque buildup, which causes a narrowing of that artery, which results in decreased blood flow to the peripheral extremities. This is a descriptive study, and it was conducted at a rural Arkansas clinic through a retrospective chart review of 50 electronic medical records. Inclusion criteria included males or females 65 years of age or older, and the exclusion criteria was males or females less than 65 years of age. The population included males and females greater than 65 years of age. Smoking status was an additional consideration, as well as coronary artery disease diagnosis. The study found that the rural clinic in Arkansas had a 0% screening rate for PAD using ABIs compared to the national average of 30%. This is just a graph chart that shows the percentages of the Arkansas rural clinic compared to the national average. This study found that the rural clinic in Arkansas was significantly lower than the national average of 30% of providers in family practice that use ABIs to screen for PAD. However, the guidelines continue to be inconsistent with screening recommendations for PAD. While the ACC and the AHA have their guidelines, the U.S. Preventive Task Force has guidelines that are still indeterminate concerning PAD. With PAD expected to continue to increase and the risk associated with PAD, which include coronary artery disease, stroke, and potential limb loss, the results of this study prove that PAD needs continued research, including the possibility of other screening methods that family care providers would be more apt to use in their practice. Acknowledgements. Dr. Christopher Jordan was my mentoring faculty, and references are as follows. Thank you.
My name is Lorenzo Soto, and I'm a student in the Masters of Athletic Training program at Arkansas State University. My research is over the association of neuromechanical factors and intercollegiate football concussion risk. Before I start, I'd like to thank all the participants that helped with this study. My mentor is Dr. Scott Bruce. He's also co-author along with Dr. Robert Bradley and Dr. Carlita Moore. The purpose of my study is to determine differences in baseline measures of sports fitness index, physiomotor reaction time, and whole body reactive agility in Division I intercollegiate football players with a history of concussion versus those without a history. There are four main symptom groups that are related to concussions. These groups include physical, cognitive, emotional, and sleep symptoms. Sports Fitness Index is an 11-question survey about previous injuries and an athlete's psychosocial state. Questions 1 through 9 ask about musculoskeletal injuries. These injuries include bone, tendon, ligaments, or a combination between these structures. Question 10 asks about the psychosocial state for the previous 12 months. Concussion history for this study was based on the responses to question 11. Physiomotor reaction time refers to recognizing and responding to visual stimuli, while whole body reactive agility offers a means to quantify right versus left performance capabilities. Here on the left, an individual is using the tracer and is reacting to targets that show on the screen. On the right is a reflection edge. The reaction time is measured based on how fast the athlete touches the squared boxes. Participants for the study were 195 players from a football bowl subdivision and a football championship subdivision team. Players were baseline tested on the reflection edge and tracer. Whole body reactive agility was assessed using lateral agility and diagonal agility of the tracer. When an avatar is projected on the monitor, athletes move toward virtual targets, eliminating them when hit. Diagonal agility is assessed when targets are shown to the back right or back left of the athlete. The individual is to hit these targets dependent on the visual cues. Metrics included reaction time, acceleration, deceleration, and speed. Physiomotor reaction time was measured by the reflection edge, using an LED light board that illuminate targets that are deactivated by touch. Baseline tests included Big G, Go No Go, and right and left hand execution, or rail for short. For Big G, a player touches the illuminated targets as quickly as possible. During Go No Go, players are instructed to ignore the red targets but touch the green ones. During rail, players are instructed to hit yellow targets with their left hand and purple with their right. Linear regression for multicollinearity reduced 102 variables to 41. Logistic regressions further reduced from 41 to 11 to 7. 3 of these predictors had an area under the curve less than 0.4, eliminating them from the model. The remaining 4 factors were question 6 from the Sports Fitness Index, lateral agility asymmetry, diagonal speed asymmetry from the tracer, and rail motor time average from the reflection edge. Players that were positive with 2 or more of these factors had a 10 times greater odds of having a concussion history. This model identified 97% of players having a concussion history. Both the reflection edge and tracer identified those whose dual task processing capabilities were deficient compared to those without a concussion history. Research has reported that 50 to 70% of athletes fail to fully disclose this information. Further research should examine if training on these 2 instruments will aid in concussion prevention. Before I end, I want to thank my mentor, Dr. Scott Bruce, co-authors, Dr. Robert Bradley and Dr. Carlita Moore, and all the participants that helped with this study.
Hi, my name is Brittany Spence. I'm a family nurse practitioner student here at Arkansas State University, on track to graduate next month. The purpose of my quality improvement project was to look at a rural clinic in Arkansas and look at their adherence to the hepatitis C screenings and guidelines in patients born between 1945 to 1965 and those considered high risk. There were new guidelines that came out in 2013 that recommended a one-time screening for patients born between 1945 and 1965, which is also called the baby boomer era. Previous IV drug users, long-term dialysis users, blood products before 1992, HIV, abnormal ALT, and if they received clotting factors before 1987. More than 3 million people in the United States are living with chronic hepatitis C, and most are asymptomatic, according to the United States Department of Health and Human Services. There are approximately more than 17,000 new hepatitis C cases reported each year, and at a more local standpoint, 22,000 people are living with hepatitis C in Arkansas. Objectives of this study was to determine if local providers in a rural health clinic in Arkansas adhered to the current hepatitis C guidelines. I analyzed 50 patients at risk for hepatitis C that were seen in the clinic from January 1st, 2019 to November 1st, 2019 to see if they were screened according to the current guidelines and compare it to the national average. This was a quality improvement project using descriptive design with a randomized convenient sample through a retrospective chart review of 50 patients. Inclusion criteria included males or females born between 1945 and 1965, and those patients considered high risk. Exclusion criteria included males or females born outside the baby boomer era if they were not considered high risk, and low risk patients. If you look at the population reviewed, 96% of the charts that I had pulled were patients born between 1945 and 1965, also considered the baby boomer era, which was no surprise to me due to being in this clinic for some time now. Most of the patients were most likely born in this time frame. The other 4% of the charts reviewed were previous IV drug users, and the other categories had 0%. My findings did show that 4% of the patients whose charts were reviewed were tested for hepatitis C. However, those 4% were the previous IV drug users' charts that I had previously pulled. I compared this to the national average of 12.8% that was found in 2013 to 2015, right after the guidelines have came out. The rural health clinic percentage of 4% was much lower than the national average, which was to be expected. My retrospective chart review of 50 patients was done in a rural health clinic in Northeast Arkansas. Most of these patients that we have seen in the past were born in the baby boomer era, so 96% of the patients' charts reviewed were born in that time frame. However, none of these patients had hepatitis C screenings that I could find. This presented a great opportunity to educate the providers in the clinic and show them my findings. I'm hoping that they will take in account my findings to help improve patient outcomes in the future. This is everything put together on one slide. This is what my poster would have looked like in person. I hope everybody could take something out of this presentation today, and I thank you for listening. I am honored to be a part of Create A-State this year, and thanks again.
My name is Philip Stokes, and the title of my project is The Analysis of the Utilization of Advanced Directives by Primary Care Providers and Discussion of Barriers of Implementation. According to the American Medical Association, an advanced directive is a tool that allows patients to discuss their healthcare goals and treatments if they were not able to make decisions for themselves. Research has concluded only 36.7% of U.S. adults have an advanced directive. Studies have shown that 80% of the older adults wish to talk to their primary care provider about advanced directives, but only 7% have the discussion. The general practitioners found a lack of time, experience, and poor access to correct administrative requirements to be barriers for drafting and completing an advanced directive. Another study found patients' barriers for advanced directives to be lack of knowledge, inadequate understanding, and complexity of the document. The researchers identified 3 areas of intervention in the study, which were providing educational information using various methods of delivery, computer-generated triggers for primary care providers to initiate the discussion, and inclusion of multidisciplinary professionals to deliver the content and clarify questions. The Medicare program spent $740.6 billion on healthcare in 2018, compared to the $710.2 billion in 2017. The Medicare program spent 40% of the $740.6 billion on hospital care in 2017. In 2019, the average household who was on Medicare spent $9,533 on health care, compared to $4,700 in 2012. In 2019, Medicare spent on average $9,304 on Arkansas residents, which is slightly lower than the national average. In 2014, 2.6 million American people died, of which 80% were Medicare recipients. Over half of the Medicare beneficiaries who died were 80 years of age or older. The average spending on descendants on Medicare in 2014 was $34,529 per person. Most of the Medicare spending on descendants was inpatient hospitalization, which came to the average of $17,574. This is more than 3 times the amount spent compared to survivors on Medicare. The Centers for Medicare and Medicaid Services have produced guidelines that reimburse providers for having conversations about advanced care directives. This was put into place to provide an incentive for providers to initiate conversations with patients about advanced directives. Providers can use CPT codes 99497 and 99498 to be reimbursed. The relative value units, also known as RVUs for the code 99497, is 2.4 with an estimated payment of $85.99. And the RVUs for the code 99498 is 2.09 with an estimated payment value of $74.88. The purpose of the Quality Improvement Project was to see if primary care providers are having discussions about advanced directives to Medicare patients 65 and older. The objective of the study is to bring awareness of the possible lack of discussion of advanced directives to the patient population with Medicare who are 65 and older. The project was conducted at a rural clinic in Northeast Arkansas. The data was collected by performing a retrospective chart audit of 50 charts that was chosen at random from 350 charts. The inclusion criteria consisted of ages 65 and older, male or female. Primary insurance was Medicare and was seen in the clinic between January 1st to November 1st, 2019. The exclusion criteria was 64 and younger, was seen in the clinic outside the dates January 1st to November 1st, 2019, and primary insurance was not Medicare. The findings revealed only 14% of the patients' charts had CPT code 99497, indicating the provider had a discussion of advanced directives with the patient. The findings reveal what the literature review predicted. The results revealed support the findings that there's a lack of discussion and completion of advanced directives. The benefits of the study brought awareness to the site and the need to improve the discussion about advanced directives with Medicare patients. After discussing with the office manager, I suggested placing a reminder in the chart of Medicare patients with chronic diseases about talking about advanced directives. This would be a minimal cost, and the office manager said she would have to speak to the providers for making the change. There were limitations to the study because it only consisted of 50 charts in one clinic, so it does not reveal a true number of the population of Northeast Arkansas. APRNs can help increase the number of patients with advanced directives by asking them of their wishes if something were to happen. This gives the opportunity for the patient to have their end-of-life wishes protected and decreases unwanted stress of family making decisions for their loved ones. I would like to acknowledge my faculty mentor, Dr. Baltz, for helping me along my project. Thank you all for your time and allowing me to present my study to create a state.
Hello, my name is Kayla Sutton, and I'm a family nurse practitioner student at Arkansas State University. I first want to thank Mrs. Otisha Hadley for her guidance and help with my quality improvement project. My project is on the prescription adherence of JNC8 guidelines for treating hypertension. About 78 million Americans ages 20 and older are currently treated for hypertension, making this disease one of the most common reasons for primary care visits. The CDC identifies high blood pressure as a primary contributing cause of death for more than 410,000 Americans in 2014. Annually, statistics have shown that hypertension and costs include more than $48.6 billion each year, including the cost of healthcare services, medications to treat high blood pressure, and missed days of work. Hypertension is known as a silent killer due to most patients having no symptoms but being diagnosed during a routine checkup with a primary care provider. The 8th Joint National Committee, also known as the JNC8, released new evidence-based hypertension guidelines that discuss treatment, targeted blood pressures, as well as medications for managing hypertension. In the non-Black population, initial antihypertensive treatment should include a thiazide diuretic, calcium channel blocker, angiotensin-converting enzyme inhibitor, or an angiotensin receptor blocker. In the Black population, initial treatment should include a thiazide diuretic or a calcium channel blocker. The purpose of this study is to compare the percentage of adults with hypertension being treated in accordance with the JNC8 guidelines in a rural clinic in Arkansas to the adherence of the previous JNC7 guidelines being 75%. Methods. This was a descriptive study conducted at a rural clinic in Arkansas through a retrospective chart review. 50 electronic charts were randomly selected between January 1st, 2019 and November 1st of 2019. The population included adults ages 30 to 60 with a diagnosis of hypertension. Inclusion criteria included both male and female patients, adults ages 30 to 60 years of age, and the diagnosis of hypertension, which is the ICD-10 code I-10. Exclusion criteria excluded adults less than 30 and greater than 60 years of age, and patients that did not have the diagnosis of hypertension. The findings concluded through the data analysis that out of the 50 charts reviewed, 90% of patients ages 30 to 60 years of age were treated in accordance to the JNC 8 guidelines in a rural clinic in Arkansas. Discussion and action plan. The results of this study concluded that the adherence of the JNC 8 guidelines for hypertension was higher than the average of 75% adherence to JNC 7 in this rural Arkansas clinic. Following evidence-based guidelines will provide a standard of care for all patients for hypertension. Future research is indicated to no adherence for a larger number of providers since this was only covering one provider. Control of hypertension will lead to decrease in yearly cost of treating hypertension and the incidence of comorbidities and deaths. The limitations of this study included that it was a small sample size of only 50 patients, data collected only in one rural clinic, and data collected was only collected from one provider. That concludes my presentation on the prescription adherence rate of JNC 8 guidelines in a rural clinic in Arkansas. Thank you.
My name is Sabrina Zerbel, and I am presenting my research over the compliance rates of type 2 diabetic eye examinations at a local clinic. Acknowledgements for this quality improvement project go to my faculty mentors, Dr. Mark Foster and Ms. Tanya Mead. Here is an overview of the poster board. Today, I will be discussing the introduction and research purpose, objectives of the study, research methodology, population, study findings, and its clinical significance to current and future practice. Diabetes affects over 100 million people in the United States. The number one cause of vision damage and loss in people ages 20 to 74 is due to diabetic retinopathy. Early detection through diabetic retinopathy screening could decrease severe vision loss by 90%. Previous studies have shown an estimated 100 to 120 million people have diabetic retinopathy, with at least 50% of those people undiagnosed. The ADA guidelines state patients with type 2 diabetes should have a diabetic retinopathy screening annually or biannually, depending on the degree of diabetic retinopathy present. Despite the overwhelming research describing the benefit of early detection and screening of diabetic retinopathy, multiple studies have shown the lack of adherence to the ADA guidelines. A national study conducted between 2010 and 2014 concluded that of the 298,383 type 2 diabetic participants, only 15.3% of those received the ADA recommended annual or biennial eye examinations. The purpose of this study is to compare diabetic eye examination rates of type 2 diabetics ages 45 to 64 at a rural family practice clinic to the 15.3% rate found in the national study. The primary objective is to determine what percentage of patients ages 45 to 64 with type 2 diabetes seen at a family practice clinic in Paragould have received the ADA recommended diabetic eye exam compared to the 15.3% rate of type 2 diabetics who received their annual or biannual eye examinations in the national study. The results of this study may provide valuable insight regarding the various factors that contribute to decreased diabetic retinopathy screenings in type 2 diabetics ages 45 to 64. A retrospective chart review was conducted for this quality improvement project. A descriptive design and randomized convenience sampling were utilized for this study at a rural clinic in Paragould, Arkansas. 50 charts were reviewed of patient office visits between January 1st to November 15th of 2019. Microsoft Excel statistical software was used to analyze the data to determine the statistical significance. Chart criteria during the review included patients, male and female, ages 45 to 64, who visited the clinic between January 1st through November 15, 2019, with an ICD-10 code of E11.9. Diabetic eye exam documentation between January 1st, 2017 through November 15, 2019 was included in the data collection to keep within the ADA recommended guidelines of annual or biennial eye exams. Exclusion criteria included age less than 45 or greater than 64, absent ICD-10 code of E11.9, and diabetic eye exams obtained before January 1st, 2017 or after November 15th of 2019. The findings from this study concluded that 22% of type 2 diabetic patients ages 45 to 64 received their ADA recommended eye exam at a rural family practice clinic in Paragould, Arkansas. That equated to 11 patients out of the 50 receiving their annual or biennial eye exam. When comparing the research findings to that of the national study, the rural Arkansas clinic did slightly better with diabetic eye examination compliance. Results were further separated by type of insurance. It is interesting to see how all the self-pay patients received their diabetic eye examination. However, over half of the patients had Blue Cross Blue Shield insurance, with only 3 out of the 28 receiving their diabetic eye exam. Diabetic eye exam compliance rates at a rural family practice clinic were found to be slightly better when compared to the national 15.3% compliance rate. Based on extensive research, the ADA recommended diabetic eye exams are beneficial in detecting microscopic optic changes in diabetics. However, few providers encourage routine screenings, and many patients are unaware of its importance in discovering irreversible eye damage. 78%, or 39 out of 50 patients from the study, had not received the ADA recommended annual or biennial eye exam. Most insurances will cover a yearly diabetic retinopathy screening. Over half of the patients in the study had Blue Cross Blue Shield insurance, with only 3 receiving a diabetic eye exam. Providers need to be aware of the study findings and its implications. There is significant room for improvement in educating patients on the importance of diabetic eye exam adherence and reporting those findings back to their primary care provider. Patients should be made aware that their insurance will most likely cover the cost, as it is a preventative screening. Providers should be diligent in referring their type 2 diabetic patients for eye screenings to detect microvascular complications before they advance to an irreversible state. These are my references for the poster board and presentation. Thank you.
Hello, this is Ashley Talent, and I am a family nurse practitioner student at Arkansas State University. I first want to thank Mrs. Otisha Hadley for her guidance with my quality improvement project. My study is called Rate of Depression Screenings for Adult Primary Care Patients. Depression is a common mental disorder that impacts people globally without discrimination against age, sex, or nationality. This disability can contribute to other diseases. Treatment of depression can improve an individual's social, work, and domestic activities. The National Institute of Mental Health states that in the United States, there is an estimated 17.3 million adults 18 and older with depression, representing 7.1% of all U.S. citizens. The United States Preventative Task Force, USPSTF, recommends screening for depression in the general adult population using a valid screening tool, such as the Patient Health Questionnaire, or PHQ-9. The purpose of this quality improvement study is to compare depression screening rates with valid screening tools of patients 18 years and older at primary care visits in a rural Central Arkansas primary care clinic to the 2017 national study findings of 4.2% of adults being screened for depression in the primary care setting, regardless of recommendations that screening be a part of routine primary care. My objectives for the study were to analyze the adherence to the USPTF recommendations for depression screenings in adults 18 years and older using a valid screening tool, and to determine and compare the depression screening adherence percentage to 4.2% adherence in the 2017 national study in the primary care setting. The method used in this study was a randomized retrospective chart review of 100 patients to determine if they were screened for depression using a valid screening tool during January 1st through October 31st, 2019. A selection report was produced through the clinic electronic health record with specific dates of service for a total of 477 patient charts, and were then randomly selected for specific data. A data collection tool was used to gather the information for gender, race, age, payment method, diagnosis, and if the patient was screened for depression using the PHQ-9. The population for this study included adults 18 years and older with a CPT code of 96127 and excluded all patients under the age of 18. The findings for my study were that the rural Central Arkansas Primary Care Clinic adhered to the USPTF guidelines in 22% of the charts reviewed, compared to 4.2% in the 2017 national study findings. The clinic that was researched was 17.8% above the 2017 national average for depression screening of adults in primary care. Evidence from this study concurred that not all providers are following USPTF recommendations for screening for depression. There is a need to educate providers on the importance of depression screening on an annual or routine basis to evaluate adults for new onset or changes in severity of depression. The rural Central Arkansas clinic studied may have had a higher adherence for depression screenings because of increased provider awareness, advances in EMR checklists, and reimbursement for screenings from private insurance, Medicaid, and Medicare. Limitations of this study include a small sample size. It may be beneficial to include a larger sample size over a longer period of time to further investigate depression screening of adults in primary care clinics. This concludes my presentation on the rate of depression screenings for adult primary care patients. Thank you.
Hello, my name is Mandy Travis, and I am a current Master of Science in Nursing student here at Arkansas State University as part of the Family Nurse Practitioner program. My quality improvement project is titled A Local Arkansas Clinic's Abdominal Aortic Aneurysm Screening Rates Compared to the National Average. I was assisted throughout this process by my clinical instructor, Leah Privet, as well as my faculty advisor, Dr. Christopher Jordan. This is the poster that I created as part of the poster presentation section for Create at State. Due to the current circumstances, we are obviously not able to present these actual posters. The following slides are a breakdown of this poster for the purposes of this online format. An abdominal aortic aneurysm, also known as a AAA, is an abnormal dilation of the aorta, causing a bulging out of this area. This can lead to complications, even death, as these can leak or completely rupture. These are considered diagnostic when the aneurysm is greater than 3 centimeters or 1.5 times the original size of the adjacent aorta. Thousands of deaths each year are credited to AAAs, specifically in those 50 to 84 years old. Most of the time, patients are unaware of this aneurysm until it ruptures. When these rupture, there's a burst of blood into the surrounding cavities of the area. The average mortality rate of these is 80%. This picture gives you a comparison of a normal aorta versus one that has an aneurysm, and you can see the bulging out and how wide this area is compared to this area. The highest risk factors for developing a AAA include someone who has ever smoked, making them 3 to 5 times more likely, as well as the male gender, making them 2/3 more likely. In adults, AAAs account for 4 to 5% of sudden death, as well as 8% of all men over the age of 65. All the prior factual information has been highly researched and led the United States Preventive Services Task Force to recommend screening all men 65 years of age who have ever smoked for a AAA using an abdominal ultrasound as preventative care. Based on this recommendation, the purpose of this quality improvement project is focused on comparing the AAA screening rates of men 65 to 75 years old who are current or foreign smokers via ultrasound at a local clinic here in Arkansas to the national average of 9.2%. This is a pie chart showing you the 9.2% ratio of those who are being properly screened versus those that are not being properly screened at the national level. This study was completed with the objective of comparing the ordering of proper screening tests for AAA detection in a local Arkansas clinic for comparison to the national average screening rates in compliance with the USPSTF recommendation. This study was performed to gather information to be synthesized for the overall improvement of compliance and knowledge for the proper screenings for AAAs in a local rural clinic in Arkansas. Prior to researching and gathering data for this quality improvement project, approval was obtained from the Institutional Review Board. The methodology chosen for this project was a retrospective chart review. 50 charts were chosen at random using the electronic health record system at the local clinic. These were charts chosen based on the inclusion and exclusion criteria, including the time frame of January 1st, 2019 to November 1st of 2019. Inclusion criteria includes male, 65 to 75 years old, and a current or former smoker. Exclusion criteria is a female, anybody less than 65 or older than 75 years old, and a never smoker. The overall results of this study concluded that the rate of proper diagnostic screenings at the local clinic in Arkansas was only 4%. This graph shows you the comparison from the national average to that of the local clinic here in Arkansas. As you can see, only 4% here in Arkansas, 9.2% in the nation, but there are also large margins for improvement. The national study also compared imaging methods that also view the aorta, include X-ray, CT, and MRI. These are not part of the recommendation due to the risk related with these tests being used just as a screening method, but if these are included, there is a drastic increase in the number of people with imaging showing the aorta. When including the other imaging methodologies, you increase by 22% at the local level and 41% at the national level. When comparing the results of this study to the national study, the Arkansas clinic completed less than half of that of the national average's screening rates. Regardless of the numbers for either average, there is a desperate need for an increase in compliance for providers across the nation based on these numbers. The overall goal of this study is to bring awareness to the screening rates of the providers for education and encouragement of compliance with the recommended screening practices. As stated prior, there's a high risk of morbidity and mortality with the rupture of a AAA. The ultimate goal is to raise awareness for proper screenings to decrease this rate. An average of 96% of the patients seen in a local clinic are not being screened as recommended. This leaves multiple patients at risk. With an ultrasound being such a low risk for a patient, this screening measure is easily completed for the essential purpose of increasing the quality of life in patients. I hope you enjoyed this presentation. Thank you for your time.
Hello, my name is Misty Van Adder. I'm a graduate student in the Family Nurse Practitioner program. My advisor is Dr. Mark Foster, and today I will be presenting my research project, Behavioral Modifications and Weight Loss. Affecting more than 35% of U.S. adults, obesity among Americans is increasing. Follow me through this presentation as I explain how finger wagging should be a thing of the past. How do we as healthcare providers motivate our patients to change their poor diet choices and sedentary lifestyles to that of a healthy one? Wag our finger at the patient and demand they lose weight? No, that doesn't work. Recognizing that obesity is cause for increasing comorbidities, the U.S. Preventative Services Task Force recommends adults with a BMI greater than or equal to 30 be offered intensive, multi-component behavioral interventions by their provider. This includes nutritional services, medication, education on weight loss, behavioral therapy, and surgical referrals. For patients to be successful in their weight loss journey, providers must change tactics. Following the U.S. Preventative Services Task Force recommendations, I followed patients on their weight loss journey at a rural family health clinic in central Arkansas to determine if weight loss behavioral interventions provided to patients compared to those who did not receive them affect their weight loss within a year. This retrospective quantitative study was conducted at a rural Arkansas clinic through a retrospective chart review of 25 electronic medical records. Simple mathematical calculations were utilized to determine the amount of change in BMI. Patients visiting the clinic between June 11, 2019 through July 31, 2019 were chosen for this retrospective quantitative study, which included patients between the ages of 19 through 64, both male and female, with a body mass index greater than or equal to 30. Those excluded were patients under 19 years of age and those over 64 years of age. Additionally, patients who did not return to the clinic for 1 year follow-up. 76% of patients had a BMI or greater than or equal to 30. Of those patients, 2 were offered a weight loss intervention. Just 2. Both patients averaged a 9% decrease in weight after 1 year. Healthcare clinics calculate a patient's BMI when they come in for a visit. Some providers stop there, others wag their fingers at the patient. The comorbidity mix among patients whose BMI were greater than or equal to 30 should be enough to prompt further investigation by the provider, not wagging their finger, but asking the patient, "How can I help you? What can we do together to get your weight down and improve or eliminate these comorbidities so that you have a better quality of life?" When I started LPN school, the first thing my instructor said was that we are here to take care of our patients and work ourselves out of a job. Advocating for our patients' health will not work us out of a job, but can lessen the number of times that a patient has to be seen by their provider or admitted to the hospital due to complications of their comorbidities. I would like to thank Dr. Mark Foster during this process. References are available upon request, and I hope you enjoyed this presentation. Thank you.
My name is Kristen Vaughn, and I'm a family nurse practitioner student at Arkansas State. The title of my presentation is Comparison of Bone Density Screening Rates Among Medicare Women at a Rural Arkansas Clinic Against the National Average. My faculty mentor for this project is Dr. Mark Foster. Osteoporosis is projected to impact nearly 14 million people by the year of 2020, most notably women over the age of 65. When we look at this on a more local level, by the year of 2030, around 66% of the population in Arkansas will be affected as well. One of the biggest concerns with osteoporosis is that it's typically referred to as a silent bone disease because so many patients don't realize that they have low bone density until they've already suffered a fragility fracture. These fractures can cause loss of independence, extensive rehab, financial burdens, and even mortality. The U.S. Preventative Services Task Force recommends that all women 65 and older receive osteoporosis screening via bone density measures. Now, Medicare covers bone density screenings every 2 years for women 65 and older, yet the CDC maintains that 40% of Medicare women report never receiving a bone density scan. In fact, in Arkansas alone, there's been a 16.8% decline in DEXA screenings and an additional 700 preventable hip fractures since the year of 2008. So the purpose of this study was to compare the rate of bone density scans in Medicare women 65 and older at a rural Arkansas clinic against the national surveyed average of 60%. This study was designed as a descriptive retrospective chart review with a randomized convenience sample of 50 charts that were collected from a family practice clinic in rural northeastern Arkansas. The study population included females aged 65 and older with primary insurance coverage through Medicare. Of the 50 charts reviewed in this study, there were 24 with documentation to support receiving a bone density scan, meaning that this rural clinic had an average screening rate of 48% when compared to the national average of 60%. The data was broken down into 6 age cohorts just to see if there were certain groups that were maybe receiving screenings more frequently than others. And the data actually suggested that those of younger ages were more likely to receive screenings because between the ages of 65 and 79, more than half of the participants actually received a scan. The most critical gap in the age groups were those that were 80 years and older, as they received screenings at a much lower rate. This is actually consistent with the literature on bone density screening, which states that older age is a negative predictor of receiving a scan. There were 2 notable limitations to this study, with the first being the relatively small sample size of 50 charts when compared to the 3,500 sample size from the national survey. And then the second limitation was the lack of diversity in this study. This study had 48 Caucasian females and 2 African American females, whereas the comparative study had a much more diverse population. So because this rural clinic sits below the national average, it stands to reason that there have to be some practical interventions that could be implemented to better promote more frequent and consistent bone density scans at the local level. More inclusive preventative health protocols and better prompting in the electronic charting system could help providers and the staff stay more aware of which patients have not received screenings and which ones are due for screenings again. And then because the nursing staff is responsible for the preventative health screenings and referrals in this clinic, staff-wide education on the policies and protocols that go along with bone density scans may help foster a team-based effort to complete them in a more timely manner. In rural areas, clinics like this one in this study function with mainly APRNs as the primary providers. So it's crucial that APRNs understand and incorporate and advocate for the proper bone health and osteoporosis screenings in their routine preventative services. I hope the findings of this study help promote better patient outcomes, higher quality of life, and longer functional independence for their aging patient populations. Thank you all so much for watching and listening, and I hope you've enjoyed this presentation.
Hello, my name is Tamario Walker. I'm a family nurse practitioner student. I will graduate May 2020, and my research is about hypertension. My research questions is, were patients over the age of 40 with an elevated blood pressure screened outside the clinic before being diagnosed with hypertension? This is my research poster. We will go through introductions and purpose, objectives, methods, student population, the findings, discussion and action plan, and the acknowledgement. As we know, hypertension affects many Americans. According to Granger and Guyton, over 70 million people are diagnosed with hypertension. Healthcare costs was over $45 billion in 2011. The United States Preventive Task Force recommends patients 18 years and older should obtain blood pressure screening. With this project, I plan to determine whether patients over 40 years old with an elevated blood pressure were screened outside the clinic before being diagnosed with hypertension. This study was conducted using random sampling with distributed statistics to conduct a retrospective chart review at an Eastern Arkansas clinic. A total of 50 charts were selected between January 1st, 2019 and November 15th, 2019. The data collected will include gender, race, age, and if the patient was screened outside the clinic before being diagnosed with hypertension. Inclusion criteria included patients that were 40 and older, male or female, diagnosed with hypertension. Also, inclusion criteria will consist of adults over the age of 40 with a diagnosis of hypertension and with the ICD-10 code of Z01.31, R030, and I10. Exclusion criteria excluded patients under 40 and not hypertensive, and patients without an ICD-10 code of Z01.31, R030, and I10. The data was only collected from the dates of January 1st, 2019, November 15th, 2019. The results of this study showed that 92% of patients were screened outside the clinic before being diagnosed with hypertension at the Eastern Arkansas Clinic. Therefore, over 90% of the clinic's patients are screened outside the clinic. The age range for this aggregate was between 43 and 61 years. The clinic practiced outside monitoring as suggested by the United States Preventive Task Force. The results found in this study are congruent with the results found in the review of the literature. But there are no outcomes to be monitored from this research study. Okay, this is the chart with the demographics. The patients that charts that I saw was white and black. It was 50 charts that I reviewed, and it breaks down into white and black, ages 40 to 49, ages 50 to 60, ages greater than 60, and male and female. So the white patients, it was only 4%. The black patient was 30%. Females, it was 14%. Males, it was 19%. Age greater than 60, it was 1%. Age 50 to 60, it was 11%. And ages 40 to 49, it was 21%. There was a breakdown of the demographics of the patient's chart that I reviewed. Discussion and plan. White coat syndrome was well noted in the discussion with possible blood pressure elevations during patient visits. It is essential that the providers rule out white coat syndrome before considering a diagnosis of hypertension. The results of the study revealed that 46 patients were screened outside the clinic before being diagnosed with hypertension, while 4 patients were diagnosed and treated without outside screening. All 46 patients' blood pressure was greater than 149/87 on multiple screenings outside the clinic. A 54-year-old Caucasian woman was not screened outside the clinic before being treated. Also, a 47-year-old black woman was not screened outside the clinic before being diagnosed and treated due to multiple comorbidities. More black men was being diagnosed with hypertension than any other race or gender. Black males ages 43 and 61 did not get screened before being diagnosed and treated. It was due to possible renal insufficiency, so the patient was started on antihypertensive medication to prevent further injury. Education is very important with pre-hypertension and hypertension patients with constant reinforcement, especially black males. This research is limited. There is not enough Caucasian patients being seen at this clinic. This research is not generalizable to the public. Acknowledgements. Dr. Christopher Jordan, is my advisor. Ms. Otisha Hadley is my clinical instructor.
My name is Patricia Waller. I'm a family nurse practitioner student at Arkansas State University College of Nursing and Health Professions. This is a comparative analysis of initial and follow-up A1C levels in type 2 diabetes patients. Diabetes is one of the most common and most expensive chronic health disorders diagnosed in the United States over the past few decades. Symptoms of type 2 diabetes often develop over several years. Many patients can have symptoms for a long time without recognizing the danger signs, and some may never notice any symptoms at all. The prevalence of type 2 diabetes increases with age and comes with a multitude of complications, including kidney failure, neuropathy, amputations, blindness, and cardiovascular disease. In order to provide adequate care for these patients, providers must detect the disease early and provide appropriate education, as well as ensure safe, effective monitoring of patients receiving treatment for type 2 diabetes. The primary purpose of this quality improvement project was to determine the rate of change in glycated hemoglobin A1C scores for patients diagnosed with type 2 diabetes. Data for this descriptive study was collected during a retrospective chart review from a rural family health clinic in central Arkansas. The random sample included a total of 50 patients. This study included both male and female patients aged 40 to 70 years old with confirmed diagnosis of type 2 diabetes based on ICD-10 coding. Data collected included patient age, sex, initial, as well as follow-up body mass index and A1C values. All appointments occurred between August 1st, 2019 and November 27th, 2019. With regards to ethical issues, a retrospective descriptive design was used, and there was no interventions which could result in possible harm to any participants. Any identifying information, such as names, date of birth, this remained anonymous and was not included in the collected data. There were no other factors taken into consideration when determining the subjects, including race, ethnicity, socioeconomic status, level of education, or any other identifying demographics. The results of this quality improvement project at the data collection site revealed 72%, which equated to 36 out of 50 charts reviewed, showed improvement in their A1C scores at their follow-up appointment. 68%, or 34 subjects, had a decrease in their BMI at their follow-up appointment. Of the 50 charts reviewed, 30 were female and 20 were male, and the average age of the subjects was 54.26 years old. The average initial BMI was 36.03, and the average follow-up was 35.23, or a 0.08% improvement. The average initial A1C was 7.98, and the average follow-up was 7.51, or a 0.47% improvement. As mentioned previously, type 2 diabetes is a significant public health concern, and this disease impacts not only patients but their caregivers and family members as well. Type 2 diabetes is a metabolic disorder characterized by insulin resistance and relative insulin deficiency, which results in hyperglycemia. To simplify this explanation, diabetes is a chronic, lifelong disease where the body has difficulty processing glucose. Instead of being used by the body, glucose builds up in the bloodstream. Over time, high blood glucose levels can severely damage almost every part of the human body, and progression from normal glucose levels to diabetes can take a decade or longer. This study will be useful by bringing awareness to gaps in screening and education for these patients. There are many modifiable risk factors, which include obesity, decreased physical activity, nutrition status, and smoking and/or alcohol intake. Diet is an important tool for managing this disease, and weight loss can help decrease the severity and even prevent the development of associated health complications related to type 2 diabetes. I would like to acknowledge and personally thank Dr. Mark Foster for his contribution as my clinical advisor throughout this project.
My name is Peyton Wiggins Courtney, and I am a Master's of Science in Nursing, Family Nurse Practitioner student here at Arkansas State University. My master's level research project was focused on provider compliance rates in implementing low-dose aspirin therapy in high-risk preeclampsia patients. Preeclampsia is defined as the new onset of hypertension or high blood pressure greater than 140 systolic and or 90 diastolic on two separate readings that are more than 4 hours apart in pregnancy, along with proteinuria and or further evidence of end organ damage after 20 weeks gestation. According to the American College of Obstetricians and Gynecologists, preeclampsia affects 10% of pregnancies worldwide and 25% of pregnancies in the United States. The United States Preventive Services Task Force recommends that any pregnant mother past 12 weeks gestation take low-dose aspirin daily if there is any indication that preeclampsia could develop later in pregnancy or if there is a previous history of preeclampsia in past pregnancies. Patients at risk include multifetal gestation, chronic hypertension, type 1 or 2 diabetes, renal disease, autoimmune disease, advanced maternal age, previous history of preeclampsia in pregnancy, obesity, and nulliparity. The primary objective for this study was to determine if women's health providers in Memphis, Tennessee were adhering to the recommendation published by the United States Preventive Services Task Force and American College of Obstetricians and Gynecologists to prescribe low-dose aspirin therapy to all pregnant patients who are considered high risk in developing preeclampsia during pregnancy. IRB approval was obtained through Arkansas State University, and the study was conducted using a retrospective chart review, where 48 charts were reviewed via electronic medical record in the obstetric and gynecologic clinic in Memphis, Tennessee. Information for this project was retrieved from June 1st, 2019 through November 1st, 2019. Inclusion criteria for this project included female pregnant patients, first-time pregnancies, second or higher pregnancies, multifetal pregnancy, history of preeclampsia in previous pregnancies, patients considered to be of advanced maternal age, postpartum patients, and patients with a history of chronic hypertension, diabetes mellitus 1 or 2, autoimmune disease, and renal disease. Exclusion criteria included any pregnant female whose gestational age was less than 12 weeks. Of the 9 patients within their first pregnancy, 44.4% took low-dose aspirin from 12 weeks gestation until delivery, and 55.6% did not take low-dose aspirin throughout their pregnancy. Of the 39 patients that were in their second or higher pregnancy, 87.2% took low-dose aspirin from 12 weeks gestation until delivery, and 12.8% did not take low-dose aspirin throughout their pregnancy. Of the 33 patients who were of advanced maternal age, 81.8% took low-dose aspirin from 12 weeks gestation until delivery, and 18.2% did not. Of the 48 patients that are included within this study, 79.2% took low-dose aspirin from 12 weeks gestation until delivery, and 20.8% did not take low-dose aspirin when it was warranted based on past medical history or age. Though this study produced high compliance results, there is still room for improvement in ensuring that all pregnant patients at high risk for preeclampsia development are advised to take low-dose aspirin to prevent potential maternal and or fetal harm. Low-dose aspirin therapy in high-risk preeclampsia patients has shown to decrease preeclampsia occurrence by 24%, preterm birth by 14%, and intrauterine growth restriction by 20%. Women's health providers should comply with the USPSTF recommendation with all future cases that include high-risk preeclampsia and provide patient education on the benefits of low-dose aspirin therapy. Further research is warranted on provider compliance in implementing low-dose aspirin therapy in patients that present a risk to developing preeclampsia during pregnancy on a national level. There is limited data available to compare the results that this study yielded to what women's health providers do in the instance of preeclampsia and low-dose aspirin therapy nationwide. I would like to thank Tammy Hawkins, my clinical advisor, for all the guidance and assistance she gave me in completing this project. I would also like to thank Arkansas State University for allowing me the opportunity to present this research to the faculty and fellow students that participated in CREATE at A-State.
Comparison of prescribing practices of primary care providers in a diabetic setting. My name is Alicia Williams, F&P student. My faculty mentor is Otisha Hadley. This slide displays my poster for Create at State. It will be explained in the following slides. Diabetes is the most common metabolic disorder seen in primary care and one of the leading causes of cardiovascular disease. Therefore, it is essential to target cardiovascular risk factors in patients with diabetes in order to minimize long-term cardiovascular complications. The purpose of this study was to determine what percent of diabetic patients at a primary care clinic in Paragould, Arkansas could benefit from statin therapy was on it compared to the national average of 55%. The primary objective of this study was to determine if a provider at the primary care clinic in Paragould, Arkansas was adherent to the 2013 American College of Cardiology and the American Heart Association clinical guidelines, which focuses on reducing the risk of atherosclerotic cardiovascular disease, which is the leading cause of morbidity and mortality for individuals with diabetes. This research study was conducted using a retrospective non-probability chart review. 50 charts were reviewed from the dates of November 1st, 2018 to November 1st, 2019. E-clinical software was used to search charts based on age, gender, ICD-10 code E11.9, and statin use. Patients 40 to 75 years of age, gender, diagnosis of type 2 diabetes, and statin use were included. Those less than 40 and greater than 75 years of age with no diagnosis of type 2 diabetes were excluded. Statistical analysis of the study revealed that the primary care clinic in Paragould, Arkansas prescribing rate of statins to diabetic patients ages 40 to 75 was 62%. 16 female patients were prescribed a statin and 8 were not. 15 male patients were prescribed a statin and 11 were not. These charts provide a great visual of data obtained from statistical analysis. This study revealed that statins are being prescribed to diabetic patients above the national average at the primary care clinic in Paragould, Arkansas. Based on the evidence of available research, there can be little doubt that statins reduce the risk of major cardiovascular events in diabetic patients. Although the provider had a prescribing rate of 62%, 38% of patients did not have a statin prescribed. The provider has a chance to prescribe statins for diabetic patients for those who qualify with future patient encounters. Acknowledgements: Faculty Advisor, Dr. Nancy Baltz. Faculty Mentor, Otisha Hadley. This is a list of references used.
I am Britt Williams, a senior student in Arkansas State University's Master of Nursing in Science Family Nurse Practitioner program. I will be presenting my quality improvement project, which compares colorectal cancer screening rates in rural Northeast Arkansas to that of the national average for the Create a State event. The title of this quality improvement project is Colorectal Cancer Screening Rates in Rural Northeast Arkansas versus the national average of 67%. My faculty mentor on this project is Dr. Christopher Jordan, who is one of my professors in the MSN program. This is my digital poster for the presentation of the project. The importance of colorectal cancer screening is that colorectal cancer is the second leading cause of cancer-related deaths in the United States, with an estimated 135,430 new diagnoses and 50,260 deaths in 2017. For the state of Arkansas, these figures were 1,582 and 595 respectively, with recent data from 2015. Colorectal cancer is a slowly evolving cancer which, through the recommended screenings by the United States Preventive Task Force, can be easily caught in the early stages and removed, decreasing morbidity and mortality from this disease. Screening may be completed through stool-based or direct visual tests such as flexible sigmoidoscopy, colonoscopy, and computed tomography colonography, with each different type having its own recommendation for intervals between screenings. The primary objective of this quality improvement project is to compare data involving colorectal screening rates in adults aged 50 to 75 in rural Northeast Arkansas to the national average, which is approximately 67%. The providers at the clinic can then use this data to determine how well their clinicians and patients are adhering to recommendations and make changes if needed. Data obtained for this project was obtained through a retrospective chart review with a randomized sample of 50 patients from the clinic's electronic medical record. Charts were reviewed through the clinic's compliance tracker for all patients between the ages of 50 and 75 for evaluation of compliance of colorectal cancer screening between January 1, 2019 and November 18, 2019. The findings from the data for this project indicated the rural Northeast Arkansas clinic had a colorectal screening rate of 58%. The national colorectal screening rate was 67%, and the rate for the state of Arkansas was 64.9%, meaning this clinic is falling behind both the national and state average. Colorectal cancer is the second leading cause of cancer-related deaths each year in the United States, accounting for 50,260 deaths nationwide in 2017. Given the slowly evolving nature of this cancer and the ability to easily remove the cancer most of the time with early diagnosis, increasing colorectal cancer screening compliance rates could have a great impact on decreasing the morbidity and mortality and the great burden of cost of treating this disease in the later stages. The rural clinic in Northeast Arkansas in which the data for this project was retrieved colorectal cancer screening compliance rate of 58%, compared to 64.9% for the state of Arkansas and 67% for the nation. Increasing the colorectal cancer screening rate to above that of the national average could have a profound impact on improving the duration and quality of lives for many Arkansans. The results of this project will be shared with the clinic in an effort to highlight the low compliance rate compared to the state and national average, so they may discuss this information internally and hopefully devise a plan to increase colorectal cancer screening rates, leading to an increased quality of life for more Arkansans. This concludes the presentation of my quality improvement project. Thank you for taking the time to view it, and my hope is that you can take away some information from this project which can be used to improve the life of yourself, your family, or your patients in clinic.
Hi, my name is Carrie Williamson, an FNP student here at ASU. My project was how do breast cancer screening rates of female patients over 40 years old in a local family practice clinic compare to the national average of 72.4% screening for breast cancer in the primary care setting. Introduction. Breast cancer is currently the leading cause of cancer deaths of females in the United States. Screening via mammography is an easy way to help diagnose breast cancer in an early stage. The United States Preventive Services Task Force recommendations regarding breast cancer screening is that all women aged 40 to 49 years old be screened on an individual risk basis. Women from 50 years old to 74 years old are recommended biannual screening mammograms. The objective of this research study, the purpose of this study is to compare screening rates of women over 40 years old in a local family practice clinic compared to the national average of 72.4% of breast cancer screening rates in a primary care setting. Screening for breast cancer through biannual mammography is imperative to detect breast cancer in an early stage to prevent mortality. Approval by ASU's IRB and the clinic management were obtained to conduct a quality improvement project retrospective chart review, comparing breast cancer screening rates of women over 40 years all the way up to 74 years old in this local rural clinic. 30 charts were chosen by a random convenient sampling method between the dates of September 2019 and December 2019. The patient population are patients seen at an urgent care in a central Arkansas rural town. This clinic sees primary care patients and urgent care patients. Participants were all established primary care patients seen within the approved time frame. 30 charts were reviewed for this quality improvement project. Clinic visits were reviewed on patients meeting certain criteria during the time frame of September 2019 and December 2019. Inclusion criteria were females between 40 years old and 74 years old. Data analysis was conducted and revealed that this local rural urgent care clinic's breast cancer screening rate was 76.7%. This being slightly higher than the national screening rate. Data was gathered through literature step of this study supports results of the study. There is room for improvement for the providers in this clinic regarding breast cancer screenings. Anticipated benefits include bringing attention to this clinic's deficit to the providers in order to fill this deficit by screening all the patients seen here for primary care patients.
Hello, my name is Adrienne Moore. I am currently in the Master's of Science in Nursing program and will be presenting my research. The title of my presentation is A Local Clinic's Osteoporosis Screening Rate in Women 65 Years and Older. This is a complete overview of what I will be presenting today, including the purpose, objectives, methods, population, findings, and discussion. So what is osteoporosis? To make it simple, it is the skeletal disease that allows the deterioration of bone tissue as well as bone mass that precipitates bone deficiencies and the risk of fractures. Of all the metabolic bone diseases, including rickets, osteomalacia, Paget's disease, and a few others, osteoporosis is the most prevalent and widely known, especially during the process of aging and menopause. Women have an exceedingly higher risk of 15.4% compared to the 4.3% of men. 71% of fractures related to osteoporosis occur in women. This is especially due to the reduction of estrogen after menopause. 50% of these women will experience a fracture. 12.3 million people in the U.S. who are 50 and older have osteoporosis, most unknowingly because it is an asymptomatic disease. The United States Preventative Task Force, a panel of experts that are involved in prevention and evidence-based medicine, recommends screening for osteoporosis to prevent fractures in women who are 65 years and older. They have determined that there is a moderate improvement in preventing fractures, which is implemented through bone density testing. Approximately 73 to 79% of women who were between 65 and 85 years of age reported having this screening in 2016. The primary objective is to compare the screening rates of osteoporosis in women 65 years and older at a rural Arkansas clinic to that of the national average that align with the recommendations for bone measurement testing from the USPTF. The study conducted will promote awareness for the significance of osteoporosis screenings. With the approval of the IRB, or Institutional Review Board, a retrospective chart review was conducted through 50 patient charts in the EMR, or electronic medical record, through a rural Arkansas clinic. Data included age, sex, and race that was collected. Charts that were reviewed were only female patients aged 65 years and older. Of the patients reviewed, an International Classification of Disease Code, or an ICD-10 of Z13.820 was needed. This code means that an encounter for the screening of osteoporosis was completed. Males and women under the age of 65 were excluded. In this study, it was found in this particular clinic that only 42% of women were being screened within these guidelines compared to the national average of 73 to 79%. 91% of these women were Caucasian. So here is a demonstration of the comparison of the local clinic and the national average. Here is the local clinic at 42%, and here is the national average of 73 to 79%. This Arkansas clinic was found to be significantly lower in average screenings compared to national rates. The importance of screenings is to prevent fractures, to reduce disability and complications of fractures in older age. Osteoporosis is an avoidable disease that can be treated through lifestyle modifications and pharmacological methods. This screening is so important because half of all postmenopausal women will experience a fracture in their lifetime. Ways that healthcare providers can be astute in completing osteoporosis screenings is a support tool that can be utilized in the EMR. This can reduce the risk of fractures by predicting when screenings need to be implemented based on age. Hopefully, through these significant findings, healthcare providers will be educated on the importance of osteoporosis screenings to prevent fractures in the future.
Hello, my name is Maribel Alvarado, and this is my Create A-State project. Are Hispanic patients in a rural health clinic with a hemoglobin A1C of 6.5% or greater diagnosed with diabetes compared to the Hispanic national average? The purpose of this study is to compare a diagnosis of diabetes with the hemoglobin A1C of 6.5% or greater in Hispanic patients at a rural clinic in Northeast Arkansas compared to the national average. According to the American Diabetes Association, type 2 diabetes diagnostic criteria involves having a fasting plasma glucose of 126 or higher, a 2-hour plasma glucose level of 200 or higher during a 75-gram oral glucose tolerance test, or a random plasma glucose of 200 or higher. The ADA also deems an A1C of greater than or equal to 6.5%. Therefore, utilizing this criterion will help answer what percent of Hispanic patients with an A1C of 6.5% or higher are diagnosed with diabetes compared to the national average of 24%. Now, guidelines in practice for patients with type 1 diabetes recommend screening for diabetic complications 5 years after diagnosis. For patients with type 2 diabetes, screening begins at diagnosis, and you screen for complications including foot exams, fundoscopic exams, urine testing for albuminuria, measurement of serum creatinine, and lipid profile. Healthy People 2020 report the percentages of U.S. adults above 18 are receiving recommended preventative care assessments and how these exams are essential for better health outcomes. This includes annual dilated eye exams, A1Cs more than twice a year, annual foot exams, daily self-monitoring of blood glucose, and ever-attended diabetes self-management classes. So the method used for this study was a randomized retrospective chart review, and it was obtained from 30 charts with the demographics focused on Hispanics amongst the age groups of 18 to 65. So there were 30 charts, and they demonstrated whether the hemoglobin A1C levels were elevated, were indicative of diabetes, prediabetes, or normal. The data showed that of the 30 charts reviewed, only 6 lab values demonstrated elevated hemoglobin A1Cs, and 11 others revealed a prediabetes level, resulting in 13 of the patients under this ethnic group not having indications of diabetes. Of the 6 cases that were considered abnormal A1C levels in diagnostic criteria for diabetes, 100% of them had been diagnosed with an ICD-10 code E11.9. A hemoglobin A1C of 5.7 to 6.4% is indicative of prediabetes or at risk of diabetes mellitus, and should be findings all clinicians have a knowledge base of and provide regular screenings for. So, to conclude this study, it did demonstrate that 100% of Hispanics with hemoglobin A1Cs were diagnosed correctly with diabetes, as recommended by the American Diabetes Association. Within this category, 20% of the charts reviewed were diagnosed diabetic Hispanics, 37% were pre-diabetics, and 43% were considered to be normal lab values. According to the national average, diabetes is prevalent in 24% of the Hispanic community and is expected to increase as further education is provided. I would like to take this time now to acknowledge Arkansas State University's Dr. Christopher Jordan for being my mentor during this process. And below you'll find my references to support the evidence used for reviewing the guidelines and research for this study. Thank you once again.